everybody. It's a great pleasure for me to open this section. Please, presentation.
The technique, can you help with the presentation?
Do you have any question before the lecture? Before the presentation will open, I would like to ask the auditorium. Please take the hand. Who of you has experience in the surgery of infectious spinal pathology, non-post-operative, but primary spinal pathology? Nobody? What? Repeat the question. Question. Okay. Who of you has experience in the surgery dedicated to primary spinal infection? All of you. No presentation. Maybe second presentation, and I will correct.
Yeah, if there is a problem with the first presentation, we can. If we have a problem with the first presentation, we can continue with second presentation. The technique? Is the second ready or first or? Okay.
I mean, thank you very much for your attention and for this pause. If we see the information which presented in the different Sorry. It doesn't work. Okay, I will try. No. Next. Please change the pointer. Okay. You can see that in the different conferences, the number of sessions which are dedicated to infectious spondylitis during the last few years progressively increased. What? As to concern the publication dedicated the different question concerning infectious spondylitis, it's in numerous publications. But if we shorten the limit, if we limit the keywords, it will not too much publication was dedicated to chronic spondylitis. Only 3,000, if we put the word chronic spondylitis, and only 2,500 publications dedicated to chronic infectious spondylitis. That is why, because the majority of publication dedicated to chronic spondylitis is concerning the question of rheumatoid and other autoimmune processes. No problem. In our institute, we have three departments which completely work in different infectious and chronic inflammatory processes in the spine. Two departments work with adult patients and one with pediatric patients. Every year we have about 3,500 patients who primarily hospitalized into our hospital. The spectrum of pathology is very wide. It's included tuberculosis spondylitis, non-specific spondylitis, non-bacterial spondylitis, and rare form of spondylitis such as the after effect of late onset neonatal sepsis and parasitic spondylitis. The big number of patients we can explain by the history, because our institute historically was specialized on the infectious pathology of skeleton. It was very simple for me to show you different X-ray, but in my opinion, it would be more interested to put attention on the principal options or principal nodes concerning chronic spondylitis. What is the criteria of chronic processes? Historically, traditionally, we put our attention only on one point. This is the timing, which could be different from pediatric and adult patient. The processes which continue more than 2 or 4 months could be created as a chronic processes. But guideline for osteomyelitis introduce another criteria for chronic osteomyelitis and chronic spondylitis too. There are clinical assessments, etiology, specific infection. The first point is, of course, TB. And treatment strategy for acute and chronic osteomyelitis and spondylitis 2 could be different because the effect of systemic chemotherapy is differ in these two pathologies. This is the points which I want to explain during the lecture. The first position, classification. Traditionally, we based on the anatomical classification of infection, which was formed in the middle of 1990s by Calderón and Larson, and it's clear for you. You know that the spinal infection differ from epidural spondylitis, spondylodiscitis, paravertebral abscesses. It's very interesting that the time when this classification was found is absolutely the same than the classification of spinal tumor, Weinstein-Beria gene classification. it's possible that that was a time when the anatomical principle was prevalent in spinal surgery. As to concern the definitions, the terminology, is it really significant differentiation between spondylitis or spondylodiscitis? I am not sure because, of course, in spondylitis, the prevalent lesion located in vertebral body. In spondylodiscitis, in intervertebral disc and close part of vertebral body. But sometimes, if we have the initial and late radiological data, we can see that the spondylodiscitis in its onset has a prevalent lesion of vertebral body. That's why, in our opinion, it's more correct to use the term osteomyelitis or spinal osteomyelitis in such situation. The visual criteria for classification is very simple. The number of affected zone, the local zone when the one vertebra affected, the non-spread lesion when one vertebral motion segment affected, and spread lesion when two and more vertebral bodies are affected. And the next criteria for classification is clinical. And this point is very important because the clinical sign could be prevalent sign for treatment strategy. And the clinical clinics of spondylitis could be complicated or non-complicated. And this is very important for surgical or non-surgical procedure. Etiology confirmation is the base point for diagnosis of different spinal pathology. In the beginning, when I asked you about what kind of spondylitis do you have in your practice, I wanted to put your attention for this slide, because this is a principal classification of spondylitis. It could be infectious or could be non-infectious. We will not explain in this lecture the post-operative spondylitis, but I want to put your attention for the right part of this slide. The continuous of diseases for non-specific, for pyogenic spondylitis could be acute, subacute, or chronic. The criteria is timing. But the center part, the specific granulomatous spondylitis is primary chronic, because for these processes characterized by primary necrotic processes, granulomatosis necrotic morphology. Pathogenesis of spondylitis could be different. It could be primary, it could be secondary, it could be connected with sepsis or with previous spinal surgery. But two factors significantly differ the continuation of spondylitis, because today we have two factors which significantly change the tactic for the treatment of spondylitis. These two factors is a widespread immunodeficiency condition, primary and secondary, and the sector factors is a drug resistance. These points, the drug resistance, concern not only TB, tuberculosis, mycobacteria, but it concerns the non-TB, non-specific processes. As to concern CRMO, or chronic non-infectious osteomyelitis, or non-infectious spondylitis, this pathology looks like well-known pathology like Calvé diseases or as a pathological fracture, but the morphology of this process is absolutely another, and treatment of this pathology is not antibiotics. The antibiotics for these inflammatory processes absolutely ineffective. This pathology have to be treated as a rheumatoid diseases, as an inflammatory diseases. As to concern non-infectious spondylitis, it's very interesting changes which we can see during the last 5 years. From one side, the mixed infection significantly increased, and now it's more than 30% of spondylitis, non-specific spondylitis, could be found by mixed flora. And the second trend is increase significance of gram-negative isolates. In some publications, we can see the compare of spondylitis caused by MRSA, MSA staphylococcus. It's interesting that there is no difference between these two pathology, between these two types of spondylitis in the level of postoperative mortality and severity of back pain. But it's significant differences in the in such signs as comorbid pathology and risk of postoperative complication in these cases. Another point for non-specific infection in spondylitis is the high level of drug resistance and especially high level of comorbid conditions. The granulomatous spondylitis is well known, and really the tuberculous spondylitis is most often in this group. But you can see in this slide absolutely different etiological spondylitis. Only left slide, only left picture concerning TB. The other spondylitis was caused by non-TB mycobacteria, by aspergillus, and by parasites. That's why the radiological data absolutely has no specificity in such type of spondylitis. Treatment strategy is depend on the previous points, which I said. Thank you very much. The clinics and imaging and morphology are the main points which influence to the type of strategy, conservative or surgical strategy, which we used for spondylitis. That is why the first position which concerning in these tactic options, that systemic antibiotics therapy in a majority cases of chronic spondylitis, chronic infection spondylitis, sorry, has a low efficacy. That's why the surgery is a rule more advantageous option. There are few tactic classifications which are used for chronic spondylitis. I just want to put your attention on the last classification, which was advised by Italian authors, which include 3 criteria for surgery. We need to estimate the type of lesion, the presence or absence of deformity, and type or absence of neurological signs in chronic spondylitis. Today, the technique of surgery in chronic infectious spondylitis is well known, and it's not the problem to operate such patient for us because we specialize in this pathology. And even if the pathology, the spondylitis associated with big abscesses, with severe deformity, by step or by combined surgery, we can completely react the good anatomical and good functional results. But the surgeon who operates such patients has to have the experience as in posterior as in anterior surgery. At the end, I want to put your attention only on 3 unexpected questions which we find when beginning to work and when we work now in patients with infectious spondylitis. The first question concerning the differences between the spondylitis caused by different flora. Candida, bacterial non-infectious, and TB infection. There is no principal differences in radiological evidence of such spondylitis. The second question, concerning the low-grade infection in spondylitis. Dr. Meyer has a beautiful lecture dedicated post-operative complications, the loosening of implants and implant-associated low-grade infection. But we need to remember that sometimes the infection, the low-grade infection, could be primarily associated with degenerative diseases, and results of the treatment of patient with these degenerative diseases associated with MODIC-1 changes better if this patient treated with antibacterial therapy. And the third question is concerning the empiric therapy, about is it necessary to confirm the etiology of spondylitis before treatment? Empiric preoperative antibacterial therapy could be effective, but it significantly decreases the level of cultural confirmation of diseases during the last surgery, and increase the risk of conversion of endoscopic therapy for the open endoscopic surgery for open surgery in cases of chronic spondylitis. That's all what I wanted to say about chronic spondylitis, chronic infectious spondylitis, and it's a great pleasure for me as chief editor of Russian bilingual journal Spinal Surgery to invite you to be not only a reader but the writer of our journal. Thank you.
Thank you very much. We have a change in the program. We continue now with the next speaker, which will be Natalia Francaviglia, with the topics percutaneous endoscopic transforaminal approach for foraminal and extraforaminal disc herniation, 5 years experience.
Okay, thank you very much, and sorry for this change of a program. The history of you want to use your you see better? Yeah. Okay, the history of the transforaminal approach or percutaneous transforaminal approach started in 1931 when Berman used the scope just to visualize the intracannular pathology. But at that time, the size of the instrumentation was so big, he was not able to continue to see something. Another doctor tried in 1938, Poole, in New York already, and he develops a special myeloscope just to see and normal inspection and if there was some abnormal structure. So, but we need to arrive in 1975 by Hausmann and Ford, who use an arthroscope to inspect the contents of the intravertebral disc following open laminectomy and discectomy. So at that time started the history of the posterolateral approach, and all of you know the Theonic technique for disc. But it's just in 1917 when Cambin and Ikata started to use the special design cannula, but at that time they used the cannula just only for go to the disc and remove the disc. It's in 1988 when Camping described for the first time the working triangle. It means a working safe zone where you can go inside the canal. Hence, why inside the canal? Before to start to speak about the transforaminal approach, I think it's important to say some speech about the foramen. The foramen is classified in 3 zones: entry in the medial part, middle, and the exit zone in the external part. And one foramen is normal, one is more or less 5 millimeters. It's stenosis when it is 3 or 4 millimeters, or stenotic less than 3 millimeters. Patients, of course, with the stenosis in the entry zone of the neuroforamen fared worse than those with the stenosis in the middle and the exit zone. And so we see later why. Using and started to work with the endoscope, we started to think which best indication we can give for this application. And in our mind, the best application for the transforaminal approach is the foraminal and the extraforaminal disco hernia that you can see here, the foraminal, the extraforaminal, and the foraminal disco hernia. Why? Because when you compare the microsurgical approach, far lateral approach, go to the foramen and remove the disco hernia, and so you compare this technique with the endoscope, it's absolutely awful to think to continue with in this particular indication. Why? Because with the spinal endoscope via transforaminal approach makes possible to visualize the medial, lateral, and ventral surface of the nerve root and the dural sacs without undue manipulation and the retraction of muscular and the neural tissue. So you need a really good pro-operative planning, because it means that when you work in the left sides, in your mind is different than in right side, because the radix is in opposite. So you need really to understand the inclination of the needle. Why? Because the target, you don't forget, is the spinal canal and not the disc. So you need to go a little bit more surfaceful. So we prefer to operate in general anesthesia in the prone position, but you need to determine perfectly way the landmark, the anatomical landmark under lateral and AP fluoroscope guidance, which are the landmark, the midline, the mid-pedicular line, the lower end plate, and the iliac crest. And you see here the landmark, and this is the point where you can go through the needle and so go inside. Why? Again, once again, just because you need to determine this special triangle where you work in a safe way. So the intersection of the needle is far lateral, as shallow as is possible. It means 30-40 degree. Why? Because when you work in this field, you don't forget that your target point is also the lower part of the foramen, while there is no radix there, so you work in a really safe way. This is the position of the needle that you can see, and this is the position of the working cannula, etc. But sometimes you need also to enlarge the external part of the foramen, so you have this special rasp or trephine, who is blind in the tip, and you see here the tip is blind. You have a cutting, side cutting, safe bone removal, and this allows you to open the foramen, so to extract without unnecessary dissection of the disc, just to remove what you need. This is the rasp, this is the position of the channel. So you see one case here, L45 disc extruded, you see the extraforaminal position, the midline is done. We simplify the technique, and here is the point between where you can go in. This is the crest iliac crest, this is the instrumentation, the working, the dilatator, the endoscope, and you see here we insert the needle, you control in the lower part of the foramen, and you start to insert you remove the needle and start to insert the dilatator, and after the dilatator you control and you are in the perfect position. You use the rasp of the facet joint and you insert it. This is what you see. What important is to go at the beginning in the bone of the facet joint to individualize the pars intermedia and remove the disc that you have just in front of you. We use a lot of the radio frequency just to remove the fibrous tissue, the fat tissue, and this is the removal of the part of the disc. This is what you see at the end of the operation. This is the wound. It's really minimally. So our results and our inclusion criteria: unilateral radicular leg pain as associated to image evidence of intra or extraforaminal hernia disc herniated, inadequate response to conservative treatment for more than 6 months, and motor weakness also. So I repeat, we perform in general anesthesia, prone position. The learning curve at the beginning is a little bit longer, but the mean time of operation is about 1 hour. And this is our casuistic. You see, the successful rate is more than 96.7, and the VAS is 8 to 1. We have one recurrent disc herniation, and still now without any complication. One microsurgical reoperation. We have to convert one operation for L5-S1, and so we have no intra and post-operative. But we have also the limits for this technique. Why? You see, the massive deformity, of course, is impossible. You never try to operate the spondylitis with this technique. When you have the dorsal stenosis of the spinal canal, it's impossible because you don't see the dorsal part. And so also, when you have a steep iliac crest or L5-S1 herniation, it's impossible to go inside the canal. Or if you have the disc fragment sequestered dorsally to the thecal sac, it's also impossible to remove because you don't see the dorsal part. The advantage of the technique, of course, is minimal blood loss, less scar tissue, less tissue trauma, no instability, possible in obese patients, faster mobilization, local anesthesia or conscious sedation, foraminotomy, and the recurrent disc herniation. Easy to operate because you use a new way and you have no scar or fibrosis. But we have also the disadvantage of the technique. It's technically demanding because the flat learning curve is really important. You need special instrumentation, and also for neurosurgeon, it's a new, because you have a new anatomical view with this transforaminal approach, but it is not easy at the beginning to understand with the exiting route and the running route for the next foraminal, and also the limits of L5-S1. Thank you very much.
Thank you very much for your lecture. Again, we have small changes in our schedule. It's a great pity, but Professor Rerich doesn't come, and Artashes Avetisian will hold the lecture instead of Victor Reirich, please. A little bit late. 15 minutes.
Good afternoon, ladies and gentlemen, dear colleagues. It's an honor for me to be here with you today. I want to say again, great thanks to the organizers of this Congress, it's a great Congress. Okay, I want to talk about the negative effects of steroid therapy in acute spinal cord injury. I'm a spine surgeon at Traumatology and Orthopedic Research Institute in Novosibirsk of Russia. We engaged in treatment of surgical treatment of patients with spinal injury, including spinal cord injury, and their consequences. The patients are delivered to us by ambulance from rural Novosibirsk region, which contains about 3 million people. And every year we have approximately from 40 to 50 cases with acute spinal cord injury per year. In our institution, it's organized a full cycle of treatment of such patients, which include emergency surgical care, intensive care, inpatient treatment, inpatient rehabilitation. As you know, spinal cord injury is a very severe injury, and fortunately very rare. According to literature data, the incidence in the world is about 15 to 40 cases per 1 million population. There are seasonal outbursts. The spinal cord injury is observed more often at warm season, and the cases are occurs at weekend. On this slide, the data from US registry of such patients. As you can see, this trauma affects most young people, young men, and that's why this trauma is actual socioeconomic problem. Spinal damage of spinal cord occurs in two phases. At the moment of trauma, when the vertebra or the fragment of body of the vertebra is displaced by the traumatic force, the concussion and anatomical damage occurs. This is a primary injury, and we can do with them nothing. If the spinal canal compression remains, the deleterious effects are occurs. In general, they include ischemia, inflammation, and cellular apoptosis. This is a secondary injury, and we can strictly reduce them by conduction, emergency decompression, and by implementation the effective pharmacological therapy. In the last 2 decades, the many attempts have been made to modify, to get more effective therapy. In literature, there are messages about the various pharmacological agents which used, such as tyrosine mesylate, GM1 ganglioside, thyrotropin release hormone, gazaclidine, naloxone, etc. All of them had very promising result in experimental stages, but nothing on clinical practice. Only common method of pharmacotherapy in acute spinal cord injury which utilize it every day, which utilize it everywhere. This is usage of high-dose steroids such as methylprednisolone. But in literature there are many reports about high incidence of complications with usage of this drug. And this is unbelievable, but its impact on neurological recovery is remain controversial. At the same time, there is another method of pharmacological therapy of such patients, which is utilized on clinical practice, is a maintenance of optimal perfusion of spinal segments by administration of vasopressors such as noradrenaline or epinephrine. But this method in nowadays don't have evidence base. That's why all of this is the basis of our research, which result I want to show you. We have two goals. The first is evaluate and determine the incidence of complications of usage of methylprednisolone and compare them of the compare them to complications with usage the vasopressors. We want to define and compare complication rate in study groups and want to know the impact of new method of maintenance of optimal perfusion in spinal segments on neurological recovery. We have a retrospective clinical trial. We collect the data of 262 patients with spinal cord injury. We include the patients which have ASIA grade from A to D and have continuous compression of spinal cord. And we had excluded the patients with drowning and thoracic injuries associated with lung contusion. All of patients underwent emergency decompression and stabilization. The follow-up period was 6 months. On this slide, the two groups of patients. First one is methylprednisolone group, or MPD. In this group, we use the methylprednisolone in standard dose, well described on literature. In another group, we create a moderate hypertension by administration of epinephrine. The statistical analysis is based on assumption that the rejection of methylprednisolone will reduce the complication rate and will not lead to worsening of the functional outcome of treatment. We use chi-square criterion. This is a case with spinal cord injury. As you can see, the patient had fracture dislocation of 5 cervical vertebrae with compression of spinal cord segments, and he had tetraplegia. He underwent close reduction, anterior decompression, and anterior plate fixation with interbody fusion. Here is our results. The frequency of causes of spinal cord injury are the same as described in literature. In this slide, you can see the distribution of patients in two groups. The spinal stenosis, compression, duration, and neurological status of patients with a similar in groups. On this slide, you can see the result of neurological changes. On postoperative follow-up examination, 32% of patients with in MPD group, where we use methylprednisolone, and 42% of patients in MAP group had improvement on neurological status, at least by 1 Asia grade. Now, despite this, there were no statistically significant differences, as you can see, p-value. Oh, differences between the result of two groups. But now let's see the complications of groups. In the group with methylprednisolone, unlike the group without it, nosocomial pneumonia and acute endobronchitis were approximately 3 times more frequent. Also, the incidence of severe complications is acute peripheral vein thrombosis, sepsis, decubital ulcers, acute respiratory distress syndrome, and surgical site infections were higher in the group with methylprednisolone. Mortality in the MPD group was 7.5%, while in the MAP group it was only 1.5%. But statistically reliable differences was observed only in nosocomial pneumonia and endobronchitis. Thus, I want to conclude that that the use of high dose of methylprednisolone leads to increased incidence of severe infections complications. Replacement of methylprednisolone therapy with the method of maintaining optimal spinal perfusion allows to significantly reduce the number of nosocomial pneumonia and acute bronchitis after surgical treatment of patients with acute spinal cord and does not compromise the neurological recovery. In our opinion, this method is promising and requires further research. Now, I want to say thank you. That's all.
Thank you for a very interesting presentation. We continue with the next speaker, minimal invasive spine surgery instrumentation in trauma. Nikolai Gobrovsky from Bulgaria.
Mr. Chairman, dear colleagues, thank you for the possibility to present the experience of the University Hospital of Pirogov and the Neurosurgical Department of this hospital in minimally invasive spinal surgery in trauma. So I will say a few words about the concept of minimally invasive spinal surgery. So basically the idea is to achieve the same clinical outcome, or at least a comparable result, by minimizing the risk of iatrogenic injury, sparing the soft tissues and by this achieving better, even better results. The main concept of minimally invasive spinal surgery is to go directly in the point of interest. So if you have to perform a transpedicular fixation, you don't do a midline incision, and, but you go directly to your pedicule, as you can see. In the same way of thinking, if you have to make a decompression of the articulation, you don't make a midline incision, but you go directly to your articulation of interest. So these are the two main options in minimally invasive spine surgery. The surgical technique consists of putting guiding wire, and in fact all the instruments, all the screws are cannulated, so the guide wire will guide you through the whole process of inserting the instruments and the screws. Regarding the decompression, you need some kind of retractors. There are different types of retractors. We prefer to use blade retractors because you can have a very good angulation. You can open your retractor, and with a very minimal skin incision, you can have access to a large part of the spine. So what are the main advantages of minimally invasive spine surgery? First, of course, this is the minimalized blood loss. This is very understandable. We have less muscle and tissue disruption. We have reduction of the rate of surgical site infection. We have reduced recovery period. We have shortened hospital stay, and we hope to have higher patient satisfaction. For the last 4 points, let's say 10 years ago, they were more or less questionable. But actually, we have a lot of data, very big, I would say a huge series, where all these questionable points have been proven. So actually, we can say that it's evidence-based that with minimally invasive spinal surgery, we have all these advantages. I would like to insert 2 more important advantages, and this is the fact that minimally invasive spine surgery is much easier to be applied in obese patient, and as a second point, that it's an important way in cases of reoperation, because you don't have to use the same way, but you have better anatomical repairs. So if we have to reiterate, basically the idea of minimally invasive spine surgery is to make big stabilization by using small incisions, as in this case. What about the disadvantages of this technique? There are 4 main disadvantages. First, this is the longer intraoperative X-ray exposure, the long learning curve, the longer operative time, and the decreased possibility for reduction. I think that at least the last 3 of these points are not really important. First, regarding the learning curve, I will make a comment at the end of my presentation. Regarding the longer operative time, I think that when you acquire experience, the operative time is completely comparable. Of course, it depends a lot if you use navigation or not, but in most of the cases, you can achieve similar operative time as in open surgery, and in many cases, you can achieve even shorter operative time because you don't have you spare the time for opening and then for closing. So I don't think that this is a real disadvantage. And regarding the decreased possibilities for reduction, I will show you this type of instrument. Actually, there are different companies are proposing different type of sets and of instruments that can do the same thing, but with one single instrument, you can achieve compression, you can achieve distraction, you can achieve reduction. So it's very versatile and very useful, quite simple. Something else. You can do this, compression, distraction, and reduction on multiple levels. This was not available in the first generation of instrumentation, but actually in the second and in the third generation, this is available in almost every company. So I think that the idea that we cannot achieve reduction is not a point anymore in this discussion. So finally, I think that the only real disadvantage is the longer intraoperative X-ray exposure. It can be reduced by neural navigation. At least in our experience, since the beginning, when we started to introduce this technique, for the first year, we reduced almost twice the X-ray exposure. So I think that when you acquire experience, and using different technique, you can reduce X-ray exposure. But even in this situation, it's more than in open surgery. So for me, this is the one and only real disadvantage of this technique. So what about minimally invasive surgery in trauma? As we know, in trauma, we have to achieve first decompression. Second, we have to achieve restoration of the normal anatomical relationships, which is the reduction. And last, we have to achieve a stabilization of the segment, eventually with good conditions for fusion. What is achievable with minimally invasive the spinal technique? I think that decompression is possible. You can go directly to the point of interest with the retractors that I mentioned. It can be tubular or blade retractors. Anyway, it's up to the equipment in your department, but these tubular or blade retractors will permit you to make a good decompression if there is a single focus, a good focus of compression. Regarding the second point, the restoration of the normal anatomical relationship, as I demonstrated with these instruments, this is absolutely possible in most of the situation. You can achieve compression, distraction, reduction, even on multiple levels. So this is actually also possible with this technique. And regarding the stabilization, I think that here there are two main questions. First, this is a fundamental question, to fuse or not to fuse. Should we fuse? As we know, in some situations this is mandatory, but there are a lot of situations where fusion will not give you additional advantage, will not give better results for your patient. So I think that we have to select the cases that we're gonna fuse, and the concept for the internal bracing, putting a stabilization for a period of 6-12 months and removing it for gaining back the mobility of the segment is something that is emerging, very interesting, and is gaining more and more field. For 5 years, we made 109 cases with traumatic fractures with minimally invasive technique. I will not go in details and statistics, but I will show you some cases that could be interesting, and we will demonstrate different type of approach. The first is of a 45-year male with after a vehicle accident with a fracture of TH12 and neurologically intact. As you can see, there is a burst fracture of TH12. We decided to go for minimally invasive surgery, and we put 6 screws. Actually, some 10 years ago, probably we would put 8 screws, 2 levels above, 2 levels below. Regarding this is the transition between the thoracic and the lumbar spine, but for the last years we are trying to use as short stabilization as possible. In this situation, 1 level above and 1 level below. But regarding our previous bad experience with 4 screws, we have started to put screws in the level that is involved if the pedicles are safe. As we know, about 80% of the pull-out strength of the screw is concentrated in the pedicle. So actually, with a short screw, we can achieve about 80% of the pull-out strength of the stabilization. Our initial results are very good. When I say initial, I mean we are doing this now for more than 5 years. And it was last week when I saw the first case of a fractured stabilization with 6 screws. Last week was the first case with fracture stabilization. We are still wondering what happened, and we shall analyze this, but for 5 years we have a lot of cases, I think, or at least several cases. And this was the first case last week when I saw a fracture stabilization at this level with short stabilization with 6 screws. The other case is of 53-year-old male who fell from about 3 meters. He was neurologically intact, but with irritation of L2 on the right. This was the CT scan. As you can see, there is a burst fracture of the vertebral body, and there is a small fragment that is in the foramen. So our decision was to go for minimally invasive decompression and stabilization. In this situation, we put 5 screws because we couldn't use the pedicle on the side of the compression. We made decompression on this side, so removed the articulation. But I think that even 5 screws are better than 4. And this is the final result with stabilization, restoration of the normal anatomical relationship. And as you can see, it took us less than 2 hours with less than 150 millimeter blood loss, which is completely comparable, and I would say even shorter than normal open surgery. The next case is 74-year-old female with a fracture of L3, bilateral irritation of L3 with severe pain, inability to stand and walk, and a severe osteoporosis. This is the X-ray and the CT scan. As you can see, this is a severe osteoporosis, fragment that is involving more than 50% of the spinal canal, and a lot of signs of instability and osteochondrosis. I mean, this is not really a nice case. So this was our decision to go for 2 screws above, 2 screws below with minimally invasive technique. We performed lateral decompression. Here you can see, oops, sorry. You can see the size of the incisions here. And this is the final comparison between preoperative and postoperative. As you can see, we have restored the kyphosis, we have made augmentation of the screws because of the osteoporosis, and we have made a posterolateral decompression that is evident and I think enough satisfactory. The next case that I would like to share with you is a 73-year-old female with severe osteoporosis with Parkinson's disease, with a lot of comorbidities and a fracture of L1. She was neurologically intact, but with severe lumbalgia and inability to stand and walk. Here again, we can see a fracture, a compressive fracture with a fragment in the canal, and our decision was to go here once again for minimally invasive surgery, and we made augmentation of all the screws, but we made also vertebroplasty at the level. This is a contemporary concept that if we make a vertebroplasty at the fractured level, we can reduce the need of anterior stabilization, of additional anterior stabilization. So the vertebroplasty represent more or less additional anterior stabilization, and in patients with poor bone quality, like in this case, I think that this can be very important. It took us about less than 3 hours with not a lot of blood loss, about 200 milliliters. And the last case is a 62-year-old female with fracture of L2. This is a case that I think is interesting. I don't think that we made the best decision, but for us this was an option. Anyway, this is an interesting case that it can be very a lot of point of discussion can be found here, and I am proposing it not an example of good clinical practice, but as an example of difficult cases that can challenge us from time to time. So he came with she has a L2 fracture operated in 2012. We have no documentation, nothing, no operative protocols, no X-rays, nothing. So she came with severe pain, inability to stand and walk. She has a sclerodermia because of this disease. She had corticosteroids for several years, and as a consequence, a severe osteoporosis. So this is what we find. It's not easy for me to explain you what is this exactly, but as you can see, there is a fracture of the vertebral body, there is a penetration of the screws, and a dissection of the vertebral body because of the screw. I have never saw this type of fixation, but anyway, this is what we found. Apparently, there was some attempt to make a posterior fusion, and apparently they do not work correctly. So this was our decision to make a VBR to replace the vertebral body. Unfortunately, the bone quality was so poor that the VBR, when we tried to distract it, penetrated above and below in the vertebral body. So we decided to go 3 levels above and 3 levels below with augmentation of the screws, and we put a lot of bone with some osteogenic, osteoconductive materials inside the cavity of the vertebral body, and this was the final result. As you can see, we achieved to restore the kyphosis with relatively good result, and we put also a brace because the the poor bone quality. This was a very challenging, difficult case, but we decided that this is probably the best solution. And the last case, a very short one, is a 59-year-old male with ankylosing spondylitis who felt at home, and he came neurologically intact but with severe local pain, and this was the result. We decided to go for minimally invasive procedure, and basically here the idea was to show you an example of C-type fracture that also can be treated by minimally invasive procedure. The result is not perfect, but I would say satisfactory. And regarding the small that we don't have a iatrogenic trauma, I think that this is a good solution. So final words about the learning curve. Usually, as every new technique, it can be difficult to make your first step, but usually with time you gain more and more experience and you become better and better. One day maybe even mythical. But in fact, in real life, the learning curve is not like this. In real life, the learning curve is like this. Usually we have our good moments and we have our bad moments, even when we are experienced. So the most important part is to persevere, to continue, because even with our bad moments, we become better and better. We learn more. As a final words, minimally invasive spinal surgery and instrumentation have impressive possibilities for reduction, distraction, compression, and reclination, even on multiple levels. Minimally invasive spinal surgery is a proven alternative for short segments spinal pathologies, but it can be a therapeutic option for complex spinal pathologies and trauma. Thank you for your attention.
Thank you very much for your report. It's very interesting. Thank you. The next presentation from the country of sun and huge population. Professor Harjinder Bhatoi, please.
Thank you, Chairperson, and I thank Professor Lukas Rasulek for giving me this opportunity to be here, and it's wonderful to be back. This is my second trip to Belgrade and to Serbia. Thank you very much for the wonderful hospitality. So before me, Professor Mushkin has given an excellent talk on spinal infections, including tuberculosis. So I think I won't have to elaborate much. So treatment of Pott's disease historically has been recorded even in mummified remains in North Egypt. It is it has been recognized as a problem even in that period. And generally it is a discocorporeal disease, that means involvement of the disc as well as the adjacent vertebra, but you may have a non-osseous atypical involvement also. Presentation is generally in the form of pain, cervicalgia. I'm talking of cervical spine. And constitutional symptoms may be accompanying, especially in children. There may be fever, weight loss, Lermit sign, visible spinal deformity, and a visible cold abscess in the neck, and a varying degree of neurological compromise, which may be in the form of radiculopathy or myelopathy. Investigations are generally, these are the investigations listed, especially now, as Professor Mushkin mentioned, the immunocompromised status is extremely important in the workup of these patients. And other investigations include radiological investigations like chest X-ray, plain radiography, CT, and MRI. Medical management constitutes anti-tuberculous therapy, which is given for a minimum period of 12 months. There are advocates who give it for 18 months. We've been giving for 12 months. That is the 4-drug regime. Who are the patients who might be taken up for conservative management? Now, there will be a distinct subgroup of patients who will be advised conservative management. So I'll be talking about surgery a little later. So these are the patients in whom ambulation is not significantly affected. Or conversely, the patients are too sick for an operative intervention. or for some reason the patient wants to avoid surgery. He's been advised surgery, he or she has been advised surgery but wants to avoid surgery. So in those patients, of course, we resort to antituberculous chemotherapy, spinal bracing, bed rest and nutrition. But one must warn the patient that there may be bony destruction, collapse and angulation which can occur even while the patient is on antituberculous treatment, which can happen. So why surgical management? Because surgical management leads to elimination of infective focus easier in the early stage, and healing can occur without deformity. And as the disease progresses, deformities can occur, especially in the first 6 months. And there is generally there is an improvement in the overall well-being after the evacuation of abscess and granulations. There is early ambulation. Very significant aspect is there is early ambulation and early return to work, early pain-free status, and it avoids the late sequelae of myelopathy as well as angulation and spinal deformity. And most important, we get an excellent tissue diagnosis, because there are sometimes there may be a mimic of tuberculosis. So therefore, we must get a tissue diagnosis. That's why the conservative management has its own drawbacks, although there are some advantages too. So my advocacy is for early intervention and early stabilization. So there are implants in pot spine which can be used quite successfully in the presence of infection. Now coming to, I'll go region wise. So firstly, the craniovertebral junction. That is the atlantoaxial, you may have an atlantoaxial dislocation because tuberculosis. There may be destruction of the C1 or C2 or the lateral mass. The patient generally presents with torticollis, myelopathy, lower cranial nerve dysfunction. And initial management is in the form of skull traction. And thereafter, a decision is taken for surgical intervention. This is an example of atlantoaxial dislocation. You can note the pre-vertebral soft tissue shadow over here. Okay, and there is a dislocation between C1 and C2. And this is the MRI of the same patient, and here you can clearly see the large collection in front in the atlantoaxial region and dislocation of C1, C2. So these are the patients who initially this was done nearly 22 years back, and initially we were doing posterior wiring of C1 and C2. Now, of course, the wiring has been given up, and one may have CVJ involvement in the form of lateral mass involvement. And in these cases, you may have to resort to a little longer segment fixation. So you may have to do an anterior decompression in the form of aspiration and posterior instrumentation. Or tuberculosis of C2 involvement with destruction of the body, and the stabilization is going to be a problem here. So we decompress this and stabilize it posteriorly by doing an occipitocervical stabilization. A typical example is of a 9-year-old male child who came bedridden. He was brought bedridden with the recent onset of incontinence and quadriparesis. Power was grade 2/3 in all the limbs, and there was slight torticollis. And this was the CT appearance, and this was the MRI appearance. And so initially he was put on skull traction, and thereafter surgery was carried out. Initially transoral decompression, and followed by posterior stabilization. This is the MRI of the same patient. There is a cold abscess, destruction of C2, and there is compression of the cord at cervicomedullary junction. And the CT also gives a fairly good idea of the bone available for spinal fixation. And this is the post-op X-ray, and this is the post-op, and there is a short video. So the child is quite well, and now almost 2 years of follow-up. He is grown up and quite healthy, and with no neurological deficits. Subaxial cervical spine, that is upper subaxial cervical spine tuberculosis, can be treated anteriorly by debridement and plating. And here's another example of long segment involvement, and this was treated again by posterior approach. Here's one patient who had a very atypical appearance in the form of just vertebral body involvement, who came only with cervicalgia. And initially we thought it was a tumor, we excised it, did a corpectomy and fixation, and it turned out to be tuberculous granulation tissue. C5 involvement in the form of compression and myelopathy, anterior decompression, anterior corpectomy, and stabilization. Again, another example of subaxial cervical spine involvement, anterior debridement, followed by stabilization. So all these patients, they had remarkable improvement as far as the pain was concerned, and they were ambulatory within a period of 24 to 48 hours, especially those patients who didn't have significant motor weakness, but of course those patients who had significant motor weakness in the form of M1 or M2 power, they took a little longer. And here's one example of an extradural lapsus along with destruction of C5, C6, and done anteriorly, and patient did well. Again, a child with a large cold lapsus and destruction of C6, C7, did anteriorly, and fixation, and thereafter the child became all right and is pursuing now college. Coming to cervicothoracic junction, now this is a tricky area in the sense that you have to be sure that the if you want to achieve fixation, you will be able to reach up to T1 or T2. So initially the presentation may be only in the form of backache or lower limb weakness. And MRI generally gives you the diagnosis. Approach can be from the lower cervical from the left side, so that we avoid the exposure, stretching of the recurrent laryngeal nerve. You can reach up to D3 level in a thin individual, and then instrumentation can be carried out. But sometimes one may have to resort to manubrium or sternal split, but this means an additional mobility. And here's one example of a recent young lady, 26-year-old. She had cervicalgia and radiculopathy with this appearance, and this is a CT showing destruction of C7. So anterior, this is the axial section of the MRI showing the cold lapsus, and the cord has been pushed back. This is the operative appearance, in which you can see the omohyoid has been, we are going below the omohyoid, and you can see the pus coming out. And thereafter, this was the post-op appearance, and the scar has healed well, and she is ambulatory, pain-free. And all these patients are taking their regular antituberculous treatment, chemotherapy. So there will be, this is another example of a cold abscess exposed, and even up to D1 or D2, cold abscess can be tackled by cervical route. This is an example of a standalone cage done nearly 15 years back, I think. So, and in which we had to do a sternotomy also for exposure. So, but the patient finally did well, and here's another child who had a C7 D1 involvement, and again exposure from the left side. The child is doing fine. There may be non-contiguous lesion, because sometimes they, as Professor Mushkin said, there may be immunocompromised patient, and these patients we expect skip lesions, and there may be some other patients who may have drug-resistant tuberculosis. So this may not be apparent clinically, and they may have a mixed symptom, that is upper motor neuron and lower motor neuron features. And osseous and non-osseous lesion can coexist. So one has to differentiate them from malignancy. So they require an oncology workup in the form of biopsy. You have to prioritize which segment needs to be tackled first. And cord compression, the aim is to have a cord decompression, pain relief, and stability. As you can see in this patient who had a cervicothoracic involvement at the cervicothoracic junction, and also a sacral involvement. So the cervical spine was treated first, followed by sacral involvement. Again, non-contiguous lesion, you have to scan the full spine and consider drug-resistant tuberculosis and changing the drug regime. Another example of a non-contiguous lesion, both the lesions, they had to be prioritized and both had to be operated. First we did the cervical and then the dorsal spine. And another example of a 35-year-old male. Again, this is not exactly a osseous involvement, but this patient was being treated for pulmonary tuberculosis and mediastinal lymphadenopathy, and thereafter he started having features of myelopathy. And MRI showed an intramedullary lesion, and his ATT was continued, and he was referred for neurosurgery consultation when his power became 0. And then we exposed the lesion, and this was on myelotomy. You can see that there was a pus discharge in the top section, and this is what on myelotomy we found. Just this short video which I wanted to show you. Okay. So this was the this was a tuberculoma which was almost getting separated like some of the videos we saw today of ependymoma. So this could be excised completely, and there was and this is complete excision, and thereafter there was marginal improvement in his power, but his sensation showed a better recovery. So this was the excised specimen, and it was confirmed to be a tuberculoma. Power remained at 2/5, but there was improved continence. So to conclude, when we talk of spinal management, we are basically talking of four spinal functions. The first function is to provide stability and avoid instability. The second spinal function is to provide a static column. Third spinal function is protection of the neural structures which are contained within. And the fourth spinal function is maintenance of neural function. And if we advise an early surgery and early stabilization, I think we are taking care of all the four spinal functions. The cervical spine tuberculosis, especially in children, is a major problem in our part of the country. Surgery has a definite role in the management of cervical spinal tuberculosis, and one should advise surgery early rather than late, because in spite of conservative treatment, in spite of anti-tuberculosis treatment, these children can worsen, and they can worsen their myelopathy, and they can develop deformities. And availability of spinal implant now, it has changed the early outcome, making the patients pain-free, arresting and reversing the neurological deficits, and enabling early ambulation. One must individualize the approach depending on the level of involvement and which is the most suitable implant for that particular patient. One must achieve adequate decompression, stability, and continue chemotherapy. And aim is early pain relief and early ambulation. So this gives a summary of the aim, that is prevent and reverse neurological deficit, prevent spinal deformity, give a pain-free neck, and achieve early ambulation. Thank you, and I take this opportunity to introduce this volume which is coming up on gunshot wound and missile injuries of the brain, spinal cord, and peripheral nerves. It will be available, being published by Thime, and will be available in the next month and a half or so. And I hope many of you will find this useful. And I also take this opportunity to invite each one of you for this Congress in New Delhi on the first weekend of April, so in which Professor Mehmet Zileli is going to be the president of the Congress. So I invite each one of you, please mark these dates, April 4th to 6th, and come over to Delhi. I'm sure you will never be disappointed. Thank you very much.
Thank you for a very nice presentation. The last speaker is not present, so we have time for a question for all the speakers of the session on discussion and comments. It was very interesting session, going from infection to minimal invasive. So if you have any question or comments. Yeah. You can use the microphone here. Yeah, it's. No.
I'm sorry. I do a good amount of TB patients in my country. I'm a consultant in Saudi Arabia. The thing is, pretty much of my patients don't have coexisting pulmonary TB with that. I need your comment on that one. And the other question is for you, sir. With the cervical spine, I'm pretty much using right now, tending to use, instead of titanium, the peak extender, which is the Vertistack or whatever in the market. Do you find any difference between the peak construct and the titanium and the recurrence of infection or destruction, anything like that? Thank you very much.
Firstly, about your association of pulmonary tuberculosis. Pulmonary tuberculosis is generally not associated because most of these tuberculosis of the spine and the bone are post-primary tuberculosis, which is because of the initial bacteremia, and they get lodged in the various parts of the body, and then thereafter, at an opportune moment, the tuberculosis process starts. So you need not have pulmonary involvement unless the patient is immunologically compromised and there is overwhelming say miliary tuberculosis or some such problem. So you may not get even a isolated hip joint tuberculosis, isolated spinal tuberculosis, isolated tuberculous meningitis. They are very well known. With no history also. You may not, patient may not have pulmonary tuberculosis in the past at all. That it's not necessary. Secondly, about the implants. Yes, peak implants are excellent. We have not used it purely out of cost constraints. And otherwise, they can be used, and I think they are an excellent alternative for the titanium implants.
I remember the article which was published in the maybe 7 or 10 years ago from Europe. I don't remember the author. Then they indicate that about 20-25% of patients with spinal tuberculosis has no evidence of acute lung TB. That's why the majority of cases, of course, it's a generalized infection, but about 20% has no lung pathology. As to concern the implants, we prefer the titanium implants, and last time we used the porous titanium, and especially when I want to ask you that especially in case of cervical TB, if the patient initially has a kyphotic deformity, and if during the surgery we correct it by Caspar instrumentation, we can use only titanium cage with outer bone for stability of the spine. Because in this situation, after we remove the Caspar destruction, the mesh is completely fused inside the vertebral bodies. We have no experience of peak implants.
If the although in the presence of some kyphotic deformity, if you correct it anteriorly, you may not require to go posteriorly also. But although the recommended teaching is that you must fix it anteriorly as well as posteriorly. But we have seen, and the follow-up is not much, maybe just a couple of years, but these patients who have fixation done only anteriorly for tuberculosis, generally they don't require a posterior fusion, because once the deformity is corrected, that stays that way, and once the fusion occurs.
Okay, other question, discussion? Okay, we have a...
This is a base principle which is recommended by WHO. But the question is, what have to be primary, the surgery or chemotherapy? If the patient has no neurological complications, the chemotherapy have to be have a beginning before surgery. If the patient has severe neurological complication, it doesn't matter. The surgery have to be before the chemotherapy.
Sometimes in the presence of severe deformity due to disease, if you can start chemotherapy, but whilst waiting for chemotherapy, you may develop an acute neurological damage by the breakage of the bone, by acute deformity of the bone. And therefore, whilst chemotherapy is good to start with, just 3 or 4 days of chemotherapy and then get on with surgery so that you can stabilize the spine, because these spines are pretty unstable and sooner or later they will need stability.
In case of a stable situation, yes. I agree.
The earlier the better. Earlier the better, to prevent sudden neurological damage.
Yes.
But in many patients, I should have mentioned before, many patients we have not used, much before the metal implants actually became popular. I've been practicing this for 30, 40 years now. We have used bone, either from iliac crest or from the fibula. And they have been pretty sturdy and pretty stable. But you need to do it very nicely, angulate it properly, and fuse it properly.
I can't completely agree with you. I'm sorry. I can't completely agree with you because our clinic have the experience more than 50 years surgery in spinal TB. The close results of the bone fusion is absolutely satisfactory, but follow-up, especially 2 or 3 years ago after surgery, indicate about 40% of instability due to pseudoarthrosis of transplant, bone transplant.
So that goes back again to money.
You're right.
It goes back again to money. Yes, this is true. One more question again. This is a very interesting topic. I apologize for that.
It's interesting.
Lately, I'm trying to drift away from surgery for especially TB patients. If I don't have that big amount of bone loss or deformity and the patient is neurologically intact, I just put them in a brace and keep them on close observation and do anti-tuberculosis treatment, and they do well. Even you recommend just going in and putting screws earlier to be away from deformity, but that's
As I said in the beginning, that not for every case, because there will be a subset of patients who may not require surgery in the first place, who have practically no deformity, just a little bit of inflammation. There'll be a little bit of inflammation, and these are the patients, and with no neurological compromise, these are the patients who can be managed conservatively. You can give them analgesics and a bracing of the spine.
And guess what? There's still big amount of patients that can do that.
Yes.
I don't know about your experience.
We have entirely broken.
Yeah, sure.
Without
Be more brave, not to do surgery.
If you have a cold abscess and if you drain that and just start on anti-tuberculosis treatment, sometimes that is sufficient. But the drainage of cold abscess is very important. If the patient has a cold abscess and if you leave that expecting it to work, the chemotherapy to work, that will not happen. You have to drain the cold abscess.
It was a very good discussion, and I think we can continue during the lunch of the discussion, even it's not a good for so thank you for the session. The lunch, it will be downstairs.
It's working. Good afternoon. We'll wait for our co-chair before we start. Stefano, hi. We're in a cramped corner. Thank you for coming. Can you hear me? Yeah? Okay, it's 2:45, so we should make a start. We have some changes in the session. The first keynote lecturer, Tito Perilla from Colombia, is absent. So we will start with Professor Keki Turel from India, who will hopefully speak to us on complications in spine surgery. Thank you.
There are two talks I'll be giving. One on complication avoidance in intramedullary tumor for half an hour, and then one talk later on complication avoidance in spine trauma. So that's a...
You want to do them consecutive?
So that will be... No, second will be somebody else, and then the third will be me again.
Right, okay. So this one is, which one is this one?
Intramedullary tumors.
Okay, so the first talk is on intramedullary tumors and complication avoidance. Thank you.
Thank you very much. So, we have a... of course, it's a great opportunity, the first time to be in Serbia after having spent so many years traveling all over the world, the first time in Serbia. And I have personal gratitude to all these gentlemen who are on the screen. And my particular thanks to Lucas, who visited us for the International Conference on Complications in Neurosurgery, which we held in Mumbai last year. And that was the picture taken at that time when he was lecturing and participating. So we talk on spinal intramedullary tumors, the technique, then pitfalls, and avoidance of complications. I have been harping on complications in neurosurgery for a while, and therefore I thought it was good to introduce the subject. Complications is a word derived from Latin word called complicare, or fold together. It's a secondary disease or condition which makes an already existing one worse. Something more intricate, difficult, or confusing, an unfavorable evolution or consequence of a disease or health condition or therapy. So this is the actual dictionary meaning of complications. But every medical field has complications. But in neurosurgery, they can be devastating. They are an unfortunate part of surgery, making the consequence worse than the original disease, and may bring great suffering to the patient and the family, tarnishing the reputation of the surgeon and also of our neurosurgical specialty at large. Keeping this in mind, we organized the first meeting last year, and now we have the second one coming soon in January 2019. And we will be having the same issues that we discussed last time, but anticipation and prevention as much important as management. There will be ethical considerations, philosophical aspects, moral obligations, and legal implications to be discussed, and frank discussions on pitfalls of management. And for a change, we will discuss not how I do it, but how I would not do it, or how I wish I had done it differently. So let us meet once again to have an open platform of discussion of our failures. Remember, failure is a defeat only if you don't learn from it. So let's go to the main subject now. Spinal intramedullary tumors, outlook towards this condition has changed phenomenally after the advent of microsurgical techniques, and total excision, as you know now, is perfectly possible with good neurological recovery. I had a personal series of a large number, but at the moment what we have been able to collect is this number of cases, 276, now about 290 cases, where we can have a good follow-up. And the number of segments involved in each of these, as you will see, a majority of tumors are going over 4 segments. So that about 60% of patients had tumor involving 4 segments or more, and every 6th patient had more than 8 segment involvement. Many of these people also had associated serings,
more with astrocytoma than with ependymoma, or equal number, I would say. And they can be, the syrinx can be proximal to the tumor or distal to the tumor, or it could be both. So here you have a patient with astrocytoma, and you see the syrinx, the tumor is outlined in red, and then the syrinx is going way above it and right up to C2. And therefore the neurological symptoms and signs may be referable to the syrinx itself. But however, after removal of the tumor, you don't need to chase the syrinx. After removal of the tumor, you will find that the spinal cord returns back to its normal shape. So the philosophy of management is assume that majority of tumors are benign and resectable. The goal is long-term control or cure with preservation of function, avoiding MRI histological prediction at the time of visuing the MRI, biopsy for confirmation during the operation. Gross determination of tumor cord interface is the most important principle of tumor removal. And the techniques are pretty well known. We have the exposure of skin, lamina, and myelotomy. Laminectomy is now avoidable. We do laminotomy and laminoplasty. Myelotomy is usually midline, but sometimes very lateral in case the tumor is extending one side. We do take pile stay sutures, especially if it's a very long lesion where you need to dissect, and you don't depend on the constant rubbing of the instruments will be avoided. Gentle dissection to find the plane of separation, staying in the same vertical plane over the entire length, because if you go zigzag, you will damage posterior columns on both sides. Minimal or no use of bipolar, preserving the vessels, even arteries and veins, even though they are crisscrossing, we try to preserve them. Copious irrigation, which means you need a very good assistant all the time. Closure of PIA, we try to do, but if it is not possible, at least the arachnoid is to be sutured or to be sealed. And the final closure with dura and lamina. We prefer to do laminoplasty because laminae will protect the spinal cord from peridural fibrosis and prevent deformity of the spine. So we make a window to engage the footplate of the tree liner cutter, and then this is the way we do it. Because of nose diving of the upper edge of the laminae, they should be cut from above downwards. And then, so what happened to the video? The videos were playing in the, they were playing, all playing in the room. In the, is it playing? It's playing? Ah, okay. It's not playing over here. So you see, this is the same problem which occurred with the other intramedullary tumors in the morning. All right, it's playing on the screen. That's pretty okay. So, I think the same problem that occurred in the morning. Okay, so I think it's on the screen. You can see it over here. It just plays and then stops. So there's nobody. Can somebody from the department?
Can anybody help?
Because there are several videos to be shown on this, or I can play with my pen drive directly. The same problem that occurred in the morning. Do you think you can play it directly from the pen drive? Will that be any better? It was playing when you were. Is it the same? No, but it stops soon afterwards. 1 second, just wait for a moment. You'll see. So it stops.
It's a video inside. Could you tell me which one is?
No, there are many videos. I can't keep on interrupting. If you want, you can play directly. Will that work?
Yes.
Done.
No, that's the same presentation. Would you like me to?
But we already saw it, it was working, you remember, in the morning. Sorry? Yeah, you can, I don't have my laptop with me.
In the meanwhile, I just to take the occasion to remind you that complicated is folded many times, and simple is semel plicatus is folded only one time. That's why simple is so simple.
You can play it on another computer if you want. Yeah, that is the one, yes, yeah. You can change the computer like this was the computer on which you worked before.
Just let me enable the content.
It's playing on the,
Yes.
but I don't know if it stops again.
I'll be here.
So it stops.
I'll bring you another laptop.
Yeah, you just change the computer. So if you are, well, see, it's changing the computer, we can continue with the PowerPoint. So in case of spinal 2, the C2 vertebra, the spinous process should be tried to be preserved so that you can have the muscle attachments back to it, and also to prevent the bleeding from the paraspinal venous plexus. So C2 is a very important lamina to be preserved, or you can split it in the midline if you need to open it wide. And then you can suture the laminae back and bring them back in place either by mini plates or by the proline stitches.
It stopped.
Yeah, it's the
Again.
same thing, it
Yes.
stops. So you checked on another computer in the morning. On which computer did you check in the morning?
It says it's playing.
Hmm?
It says like it's playing.
Yeah, but it is not playing. Your bar is moving, but it's not. Without the videos? All
Not
technique,
all.
all techniques, there are so many videos.
It should work on other videos.
You
Maybe.
You try it on a computer which accepts the Windows. This is probably for Macintosh, for Apple.
That I don't know.
Yeah, so anybody who has a Windows configuration.
This
it'll
is
work.
Windows.
Yeah, it does work, does not. So what should we do? Let us see. Let us try the next video. So So we can see the post-laminoplasty. After we put the lamina back, you can have a very nice reconstruction, as you can see over here in the cervical spine. In the earlier years, we used to do laminectomy. This was a lady who had a cervical cord ependymoma, and we did a laminectomy. This was some 25 years ago or 30 years ago. And post-laminectomy, she developed more kyphosis. So this was a preoperative X-ray, early post-op, and then late post-op. And she came with very severe neck pain. And so then, those days we had those simple DW plates, but we fused the spine, and she was relieved of the neck pain. It's very important to understand the anatomy of the spinal cord, and you need to go right in the midline. To avoid complications, you need to stay exactly between the posterior columns, right in the midline, so that you don't damage them, because quite often the difficulty of walking post-operatively is not because of loss of power, but because of loss of position sense. And this happens if you fail to remain strictly in the midline. So for a midline tumor, you remain exactly between, and identification of the midline, therefore, is one of the most important parts of this operation. So if the tumor is in the midline, you will look at the myelotomy in the midline. But if the tumor is lateral, as you see over here, then it's exactly at the root entry zone, where you will avoid the corticospinal fibers. So you're working between the midline over here, the posterior columns, and the corticospinal tract, lateral myelotomy. So you identify the midline as a shallow groove here between the two posterior columns. It's a midpoint between root entry zone on both sides, and the surest confirmative sign, so between two root entry zones on both sides, sometimes you can measure it and exactly come to the midline. It may not be visible at all. Or you can know by the dipping of the vessels, the subcommissural vessels dipping inside the posterior column on both sides. And that is a sure sign of a midline. So sometimes you may not be able to identify it, especially if the tumor has become too expanded. In such cases, one may enter the midline from the adjacent normal cord. And that is why I find that you expose one lamina above and below so that you have a perfect identification of the normal cord so that you don't damage the midline. So risk of inaccurate midline myelotomy causes posterior column impairment, and is one of the most important causes of inability to walk. So you can compensate for motor weakness, but not for the loss of joint position sense. And the lateral myelotomy is indicated in tumors located laterally and not near the posterior median sulcus, and the incision is made on the DRES zone. So direct approach sometimes is made directly over the lesion when the tumor is exophyting. And this happens quite often in subpial hemangioblastomas. So this is an example of a spinal cord being exposed, and you can see the midline raphe, and exactly dissected in the midline with two posterior columns intact, and the tumor being excised very conveniently, with posterior columns remaining completely untouched. So the technical principles of tumor removal are adequate bone dural exposure, myelotomy over the entire rostrocaudal extent of the solid tumor, identify the dorsal tumor surface, identify the poles and the cysts which are frequently seen at the end, pile traction sutures, biopsy, develop a plane of traction, counter-traction. If feasible, try to remove tumor in toto, otherwise you can do an internal decompression. CUSA for debulking the tumor. And sometimes intraoperative ultrasound, very useful, especially for locating small tumors which do not cause a significant cord expansion. So ultrasound, intraoperative sonography, very crucial. We heard also in the morning about intraoperative monitoring, motor evoked potentials, so sensory evoked potentials, the D wave, the importance of D wave. We find it a little expensive to monitor D wave in our country, but D wave and muscle MEPs must be interpreted together. So loss of MEPs during surgery suggests temporary disruption, but if the D wave amplitude drops less than 50%, then patient has a significant motor deficit. So here we have the MEPs being recorded, SSCPs being recorded. You see the operation in progress, well, me sitting at the end of the table and operating. At the end, we do the closure by closing the pia as far as possible to restore the cord shape, but it is not advisable when the cord is swollen or when you have a high-grade glioma. Arachnoid is closed with 5-0 or 6-0 proline, but you can also just weld it together by bipolar. It's very easy to close it with bipolar, but you must cut the arachnoid in a nice single plane and not in a very ragged manner. The dura is closed watertight in a running fashion, and you do a lax duroplasty in high-grade glioma after decompression. So here, I hope the videos will work. This is a medical doctor who had low back pain, and he had this tumor at the D3 to D10, and it's working. Woo! So there you have a midline myelotomy. Staying in the midline, coagulating the vessels which are entering the tumor, leaving the vessels which are stuck to the spinal cord, very carefully developing a plane between the cord and the tumor. You can see all these flimsy strands are simply dissected away, and with one hand on the tumor forceps, holding one end of the tumor, and with the other hand dissecting. The assistant's role is very important here for irrigation, so that you can have a plane which is free of any blood. You can see the tumor peeling off very nicely from the cord, and then on the right hand side, and there you can see the doctor. He's walking very freely post-operatively, and he still has a mild foot weakness, as you can see, but he has recovered completely otherwise. Ependymomas are midline and well-circumscribed tumors and therefore dissectable from the cord matter and can be completely excised in most instances. The one you see on your left-hand side is a tumor going into the medulla and going up to D2 or D3. And you can see on the right-hand side, at the end of tumor removal, a very thin, pencil-like cord. And you'll see the patient. This is the preoperative. He is not able to walk. His legs are weak. His upper limbs are very lean and wasted. So I start with the operation at the upper end because there was a cyst which I could see on the MRI. So I'm opening the arachnoid, decompressing the cyst so that I can get a pole of the tumor separated from the cord. And then I'm holding the tumor with a tumor forceps, creating a plane. At some places I find that it's becoming a little infiltrating, not very easy. So I go down, I do a full myelotomy and go down to the lower end and find the tip of the spinal cord. I always prefer to dissect from one end to the other. And so I pick it up from below. And you can see a large bulky tumor coming out from one end. So right to left, left to right, picking up the tumor, it's almost looking like a huge sausage. You can see how big the tumor is. Most people might probably do removal with a CUSA. Immediate post-operative, he starts moving his legs. His hands are still weak, but then he recovers fully. And after 5 years, he remains tumor-free. But you can see that this pencil-like thin cord functioning perfectly normal. He has no neurological deficit after this operation. Astrocytomas are mostly pilocytic. They tend to be eccentric and patchy and not always possible to remove completely. MRI cannot be helpful in distinguishing the operability. You should not determine by seeing the MRI whether you can remove it or not. You should always believe that they are operable. Debulking may often suffice, but remember, if they are infiltrating, quality of life is very important. Malignant gliomas, there may be no cure, only palliation. And sometimes pilocytic astrocytomas also are challenging, also may be difficult to completely excise, and they may respond to temozolomide. So here we have this astrocytoma. This is an intraoperative view. These are all very old videos taken on VHS camera, video cassettes. And you can see a very diffuse, very well-defined but gray, deep gray colored tumor separating out in a cervical cord. So who said astrocytomas are difficult to dissect? Most of them are easy. Maybe 20 to 30% are infiltrating, but most of them are possible to dissect completely. Even grade 2, and sometimes even grade 3. But grade 3 are considered to be malignant. So here you can see him neurologically quite good. And again, see his preoperative spinal cord and see his post-op cord. Post-op cord is thin, pencil-like. And see the scalloping of the vertebral column because of a long-standing pilocytic astrocytoma. We move on to hemangioblastomas, which are very well described, highly vascularized tumors, well defined, and you can see the edema. The point I'm bringing over here is you see the spinal cord. Sometimes even a very tiny hemangioblastoma can produce huge amount of edema over the entire cord. And this produces expansion of the cord. This was a young man from Kashmir. I have half an hour.
You have 7 minutes more.
But I lost some time. And you can see me, I can pick up these vessels from the midline and I dissect them out from the pia mater. So I mobilize these vessels, I do not coagulate them. You hold them and move them away so that you can dissect the spinal cord, the vessels, and not coagulate them as far as possible. Then you identify the midline. And then you open the midline, as I always said, make a sharp pial dissection, identify the hemangioblastoma from the periphery. This is one tumor which you do not do intratumoral debulking, and catch the arterial feeders on the surface of the tumor. Shrink the tumor. You can shrink this tumor and make it smaller by coagulation. Cut the peripheral vessels, and at the end, cut the draining vein and get the tumor out. Suture the pia mater, arachnoid mater. You can see all the blood vessels I have mobilized from midline to one side. And post-operatively, this is the tumor. You can see his post-operative, how edematous the cord is. But look at this boy, absolutely intact. This boy was from Kashmir and is no neurological deficit, 17 years old. Epidermoids are well circumscribed and therefore dissectable from cord matter and can be completely excised most of the times. The capsule may sometimes be adherent and should be left behind to avoid cord trauma. There's a lady preoperatively cannot walk, posterior column impairment as well as corticospinal impairment. Identify the epidermoid, open the arachnoid very gently in a straightforward manner. You can see the epidermoid already on the surface. Make a decision on where the midline is, very important. But in this case, the epidermoid is coming to the surface. So as I said, when you have a surfacing tumor, you can open the tumor directly over there and enter from the tumor. And then you find the tumor and the cord interface from the capsule. Bit by bit, there may be blood vessels crossing from right to left, as you can see in this case, in which case you can do a skip myelotomy. That means you have a myelotomy lower down, then you work from the other side of the myelotomy. So leaving the blood vessel in between intact, you do a skip myelotomy, work above the myelotomy, work above the blood vessel, and work below it, and get the tumor out. I like to preserve all these blood vessels. Some of the surgeons say there is nothing wrong in coagulating and getting rid of it. It's very inconvenient to operate with this blood vessel, but it is good for the patient. And this is a way to avoid complications, I feel. Because you need to give the patient a better quality of life. So this way, we excise the tumor completely, and then bring the arachnoid together, and just use a little bipolar, and you can close the arachnoid. I call it welding, like you do a electrical welding, and there the arachnoid is closed. You need to close it, and then the dura is closed, and then the bone are put back. And post-operatively, she's still immediate post-operative, she still has to recover. Okay. And I will show you the last patient of a gentleman who was gradually quadriplegic, became completely paraplegic and wheelchair bound. For 3 years, he was not able to walk. And he had no neurosurgeon in my country who was willing to operate because the tumor was going up in the cervical cord. His upper limbs were still a little moving. And if you damage this, he will be on a permanent ventilator So this is the reason why no one wanted to operate on him. For 3 years, he was moving in a wheelchair, and then finally he contacted me, and I said, yes, we can do this. We have done many multi-level operations, and so we start from one end. As I told you, I like to pick up the pole of the tumor because that's the place where it is the thinnest. So you pick up the pole and do a good myelotomy all around, and pick up the pole and gently pick up the tumor, create an interface between the tumor and the cord. Be extremely gentle. Intramedullary tumor surgery is more difficult than brain tumor surgery. You cannot afford to damage a single fiber. And quite often you will see in all my videos, I'd like to remove the tumor in one piece. There may be some criticism, but this is the way it works with me. I find it very convenient to remove these tumors in one piece. So you have a good control, and you can roll it, turn it from one side to the other, from below, above, right to left, and get the whole tumor out. So this is a huge tumor. It is bigger than the one I showed you at the beginning, and at the end, coagulating on the surface of the tumor. And you can see now, it's a huge tumor. You wonder where the spinal cord can be. And when you see this tumor, you really, amazing neural plasticity. If you do not damage the cord at all, you will find that the cord will recover, irrespective of the size of the tumor. This tumor is more than almost 27, 28 centimeters long. And you can see the cord expansion at C5, C6 area. It's looking like a salamander. And postoperatively, he's sitting with his own specimen, very happy.
Sorry, your time is over.
Yes. So 9 months postoperative. Okay. And then he is now walking with support. He started moving his legs. All right. So since my time is up, I should just say postoperative care. All these things you already know. The surgical outcome is decided by less favorable when it is dorsal cord and conus region. In fact, cervical and cervicomedullary tumors are quite resectable with very good results. Number of segments do not affect the degree of resection. And be careful about very large tumors and very small tumors. Please remember, careful case selection, respect anatomy. I do not operate on asymptomatic tumors. Be patient, don't forget quality of life. The veins may cross from one side to the other, try to preserve them. Anterior spinal artery supplies the tumor at its depth. It must be preserved. Evoke potentials, most useful, especially when plane of dissection is difficult. So, chronicity and significant pre-op deficits are strong determining factors which affect the post-op outcome. Now, we saw this gentleman was 3 years in wheelchair, in spite of which he started walking. Don't give up. So identification of the midline, very important. And my last slide again, please do come for this wonderful educational initiative, second international conference on complications in neurosurgery in January 25, 26, 27, where we'll discuss all the bad news, how we damaged our patients, how we did not prevent complications, and how we solved them also. So please come and learn from each other. Thank you very much. Dhanyavad. Namaste.
Thank you, Professor Turel. Any questions, please, before we move on? Any questions on this important topic?
I have a question.
One from Professor Ferraresi.
I have a question. What is your attitude in those patients who incidentally have a finding of cervical tumor? They have minor symptoms like ache in the cervical area and something else, because we know that when we have deficit, it is more difficult to recover. What is your attitude in truly asymptomatic or incidental findings?
Yes, partly depends on the age of the patient. I think if he is an elderly patient, I would wait. If he is a young patient, it is likely that the tumor will progress. You can still keep them under observation for 6 months or 1 year, and with the slightest development of new signs, you can operate. But this is only for asymptomatic patients. If the patient is already symptomatic, then I would operate. But you must discuss with the patient all the details. Surely.
One more question.
It's not a question, just a comment on two things the professor has just said. Yes, irrigation is very important. I totally agree with that. I myself had a pneumoma patient after operating 24 hours, was moving his legs, everything is all right. I think he had a vascular injury. After that, he got paraplegic. But I believe irrigation is quite well. Another comment about you saying abdomen, brain, spinal cord is more sensitive. And I have to believe that brain is like your mom. She will forgive. Spinal cord is like your wife. She forgets, but never forgets.
Very good comment. One final question from me, if I may. Often questioned but never resolved. Should we stabilize against potential kyphosis? What is your personal strategy?
I think if it is cervical cord or lumbar spine, I would stabilize. Stabilize means put the laminae back. I would just do a laminoplasty, and that is enough. You can put mini plates. That's what I do. I put mini plates, put the laminae back, and that is enough.
Do you have long-term follow-up on that?
Yes, we have patients. Well, cervical spine does extremely well. Lumbar spine, depending on his occupation, his posture, they may develop a little chronic back pain sometimes. And in the dorsal cord, if it is a 2 or 3 segment, you need not do a laminoplasty because they have a natural curvature. But I have seen some of these patients in whom I have not done it, they develop more kyphosis. So I try to do it every patient, laminotomy, laminoplasty, as a rule, because I think I protect the cord also.
Great. Thanks very much. Let's move on swiftly to the next speaker. May I call Dmitry Asyutin from Russia? And the talk is for 15 minutes. On the clock will be Spine and Spinal Cord Disorders, Advanced Treatment Concept.
Dear colleagues, dear chairman, thank you very much. My message won't take more than 50 minutes, be sure. And I represent, and I want to thank, first of all, I want to thank the organizing committee, the president of the Congress, for this wonderful opportunity to share with you our experience, and I'm proud to present on this conference spinal department of Burdenko Neurosurgical Institution in Moscow, and my chief and my colleagues. I want to thank them too, all our team, for cooperation in this work. I want to take your attention and start from this short. Oh, I'm sorry, it's not working.
Technical support, please. I think you might as well have a chair next to the podium.
What's happening? Maybe somewhere there. It's not.
No.
You sure?
Did you try
Let's do it.
to restart?
Yep.
Replug?
Yes. Yep. Okay. Thank you. I want to start from this short video of extramedullary tumor removal via minimally invasive approach. I'm sure that most of you already did such a kind of surgery and did it well and make it well, and it's quite an comfort and safe and maybe sometimes easy surgery, and you can see that traditional microsurgical techniques allows us to remove such a kind of tumor radically and safely for the patients. And that's why, so this is the last types of removal, this tumor. Yeah, and that's it.
So we tried to, based on our experience, we decided to answer the question, what method should we choose and in what time? Standard or MIS? And what kind of patients should be treated on? And is there any kind of benefits we are using MIS technology? Over 100 patients with different intradural extramedullary tumors pass through our spinal department every year, and the amount of such patients increases. Last period we start to use MIS approach very often to treat such a kind of tumors. And we analyze publications in PubMed library using these topics. You can see this one. And can mention that the interest of spinal surgeons to MIS technology in spinal cord tumors removal are increasing, and besides that, management of such a kind of patients with spinal cord tumors became very popular direction of research. Let's stop on result of our Chinese colleagues. They proved that the lateral base dural tacking via MIS approach get 46% larger dural window against dorsal median incision via laminectomy. That's interesting. And there is another article research that convincingly prove high economic effectiveness of minimally invasive tumor surgery versus open surgery. And the cost analysis shows us the dramatic difference in total changes per each patient, and it can reach $40,000. So our main purpose is surgical result, you know it, and to get better surgical result, we have to solve these well-known tasks. So first of all, using MIS, we reduce traumatization and risk of complications. Adequate pre, peri, and post-operative assessment provides to surgery's service safety and quality improvement. Core trends of this treatment line, such as safety, surgery safety, we're using MIS, faster recovery after surgery with minimal traumatization and low risk of complications, multimodal approach providing close interaction of related specialists of different specialties, assessment through evidence-based medicine, and consistent technological process allows to get optimal treatment result. These trends were united in well-known fast-track surgery concept. And this is the algorithm. I'm sure that it's well known. I won't stop on it. And this is according to this multimodal approach. The working group consists of neurologists, rehab therapists, physical therapists, nurses, anesthesiologists, and of course we are neurosurgeons. Extremely important to inform patient about upcoming treatment process, potential risk, and recovery program development. In our opinion, one of the best way to give such a kind of information using different illustrated methodological toolkit. On slide you can see one of such a toolkit that was created by our working group. There are well-known MIS advantages. MIS advantages provides minimization and of surgical aggression, and the operating room should be well equipped with modern surgical instrumentation, neuromonitors, visualization system, and other. We compared two small groups of patients with the intradural extramedullary tumor. One of group was treated by a standard protocol, and the other one by the MIS technology plus fast-track recovery. Patients with meningioma, nevrinoma, ependymoma, and ependymoma filum terminale and neurofibroma were included in our research, and with the tumors of no ventral localization on cervical and thoracic level, and not more than 2 segments. So to check the outcome, we can measure only pain relief by the obvious reason. And this is the standard protocol, this clinical case with a guy with ependymoma T12 who was treated via standard protocol. We used dorsal median approach with laminectomy. You can see the stages of tumor removal, and there was a hemorrhage in the tumor, and dura closure and the laminoplastic by a classic method. Usually we use such a titanium plates, but not this time, unfortunately, and getting a good result with activization on 3rd day and leaving hospital on 9th. So you can see that this guy is okay. And there is a clinical case of MIS plus fast track protocol implementation, L3 ependymoma, or schwannoma, I'm sorry. And using a tubular retractor through hemilaminectomy window, we can safely, totally remove the encapsulated tumor. And the CT post-op and the incision size and MRI control after 3 months. So another clinical case, L4 ependymoma, the same. We used the same tubular retractor with the hemilaminectomy. Let me show you. Yep. And the incision of the dura by the lateral base. Traditional microsurgical technique helps to find filum terminally, cross it, and after that remove. Yep, cross it from the back and remove the quite big tumor totally. MRI control. After that we make yes, this is the MRI control, and this lady leave the hospital on the 5th day. So, and one more clinical case of meningioma on craniovertebral junction level. The same approach, slight resection of C1 arc, and we can see that opening the dura. After that, we can see the C1 nerve root and the nervus abducens right there, flattened on the tumor, and we can easily visualize the attachment area, and with minimal traction of nerve root, we can easily remove this tumor. So, like this, the hemostas, and even separate the matrix, of course, via small incision of dura and via small minimally invasive approach. The control. Yep. So postoperative pain management protocol is traditional, and the wound care after MIS approach is much easier. Our patients are well informed on every stage of treatment process, and as I already said, the toolkit became a very useful instrument for that. During remote period, patients get special restrictions about their physical activity, but these rules are very individual in every case. And in this way, we succeed in routine usage of MIS plus fast-track protocol treatment in spinal cord tumor surgery, not only for the degenerative lumbar spine. Our results on VAS scale assessment were significant, but there were no significant difference in other neurological disorders. And MIS provides up to 30 minutes of median time economy and blood loss, and this was significantly less, besides too low actuality of this parameter during such a kind of surgery. And we can say that a 2 times shorter hospital stay and a better patient satisfaction were significant alignment. Very important point that there is no increase of complication rates due to MIS surgery, but early mobilization provides greater clinical effect. So using MIS surgery in comparison with fast-track recovery protocol on condition of differentiated patient selection provide better quality, safety, lower risk of complication, and a higher cost effectiveness. Our takeaway message for time economy, I won't stop on it. And due to our opinion, MIS and fast-track rehabilitation is the key to get better result in spinal cord surgery. This is a very actual transcript for MIS, as I guess. Try to make it simple. So thanks from our team, from our colleague, for this invitation. Thank you for your attention.
May I ask you a short question? Sometimes we see from patients with intramedullary tumors deformity of the spine, and what do you think? Should we make surgery on the one stage, or should separate stage for remove tumors and after this perform correction deformity?
If it would be necessary, of course. Yeah, sure. We won't do any kind of stabilization and any kind of correction during the tumor removal surgery. No, never.
Thank you.
Thank you.
Nikolai?
It's less chance to get neurological deficit. So I think it's better to split it. It's my opinion. And today you heard about lecture of Sala, who told us that when you have a damaged spinal cord, you have to wait. So this is the same. You have to wait. You split these two incisions. Thank you.
I agree with this opinion.
Thank you.
Thank you.
Thanks again.
Can I quickly ask the Burdenko team? You say you have 100 cases a year of intramedullary tumors. What is your catchment area? What's the population you cover?
It's Moscow region, and all over the country, because we work in the federal government center, the biggest in the world for that time. And patients came to us from all over the country and from all the past USSR, actually.
Thank you.
Thanks.
Next presentation, Emil Esengulyan. No. Wait. Emil Esengulyan, chronic spinal cord stimulation in the treatment of failed back surgery syndrome.
Dear chairmen, dear colleagues, first of all, I want to express my gratitude for inviting me this great and impressive congress. First slide, please.
Technical support, please.
Which one is yours?
My message about spinal cord stimulation possibility in the treatment of failed back surgery syndrome. Failed back surgery syndrome, we can define it as a surgical end stage after one or several operative interventions on the spine axis. After that, the pain remain or even worsened. And it is important that it can be even after a fully successful surgery. There are many reasons to lead this syndrome, and we can divide it in two big groups. Preoperative factors, in which predominant we have psychogenic factors and postoperative factors. That can divide it in factors who need second operation and who don't need. For example, when we have repeated disc herniation or instability or some complication like damaged fusion system or infection complication, it needs to be a second operation. But many times we haven't any target for second operation, but patient have still complain for pain. And this pain can related some dynamic factors, for example, myofascial tonic pain or facet joint pain, or maybe micro instability, but many times we have neuropathic pain as a constant pain and constant and paroxysmal pain, neuropathic pain. And in these cases, we can help our patients with neuromodulation, predominantly spinal cord stimulation. Now we have several options for spinal cord stimulation. Tonic conventional spinal cord stimulation, high frequency 10 Hz spinal cord stimulation, burst stimulation, and DRG, dorsal root ganglion stimulation now. And also we have morphine pump for chronic intrathecal therapy. For conventional tonic spinal cord stimulation, we have two big study, RST, that display good results, spinal cord stimulation in patients with Walbeck surgery syndrome. This is well-known North and Kumar studies, but these studies underline that in cases with leg pain, we have more effective results than in back pain. So, in throwing times, the technology growing and rises new waveforms for stimulation, high frequency stimulation in 10 Hz. This is a well-known European study. You can see that high frequency stimulation can help patients with leg pain and back pain too, as well. Well-known Senza study included 200 patients, and you can see 20% more than traditional conventional tonic stimulation help patients with leg and back pain. Best stimulation, like high-frequency stimulation, no paresthesia, paresthesia-free stimulation. And it helps patients, and moreover, besides, we can influence not only a dorsal column, but a limbic system. This is most important because it's influence for psychogenic component of pain. And DRG stimulation very important when we have pain with very narrow area. For example, the external bridge of feet. This is severe pain. Then many times this patient needs opioid analgesic for this pain. But if we perform DRG stimulation, direct stimulation or dorsal root ganglion, especially for feet, we can help these patients. And in this slide, you can see well-known accurate study that show improvement results when we use this technology. In our study, we included 100 patients whom we can taking follow-up, mean duration 5.5 years. Most of them we use tonic stimulation, and only 10 patients high frequency stimulation, because before last 2 years we can perform only conventional stimulation, but last 2 years we also use 10 Hz stimulation and burst stimulation, and I hope in next year we try to DRG stimulation too. Pain and quality of life measurement, brief pain inventory scale, and our study have some limitations because retrospective, single center, and without control group. In the early postoperative period, we have a good result and not so bad in the follow-up, but in 20% of patients diminish their successful results after several years. And 12 of them, we removed system completely. If we look at this slide, we can see the VAS core dynamic and also medicament consumption decreased in many patients, and improved activity as movement activity, as social activity as well. And when we analyzed some factors that influenced our results, we find that open surgery before SCS and duration of pain very influencing on results. And finally, I want to display you one interesting case. A woman, 39 years, who had simple surgery for disc herniation, but pain still remained. And after that, 2 years later, she her performed decompression without fusion, and 3 years later, the compression with interbody fusion. And pains remain, and we implanted here 2 octopolar leads for tonic conventional stimulation with very good results, as you show. But 2 years after, her pain worsened, and add your neuropathic pain that he completely control with neurostimulation. At this pain, vertebrogenic pain, related with some instability. But she denied possibility of open surgery, and they try their morphine test with good result and implant fully system. And after that, you can see our results, pain and background pain and paroxysmal pain dramatically decrease. And we look them about 4 years, and the result is stable. In conclusion, chronic spinal cord stimulation safe and effective for patients with Feldbeck surgery syndrome. Careful patient selection is needed. All unsatisfactory results in our series and deterioration of positive result were observed in patients with dramatically psychogenic component of pain. Neuropathic character of pain most important for patient selection, because movement-dependent pain responds worsen to SCS. Results are also influenced by pain anamnesis, duration, and number of spine surgery with open access. Long-term unsuccessful medical treatment decrease potential effectiveness of neurostimulation. Thank you for your attention.
Congratulations, especially also for keeping on time. We have time for a question or two from anyone. Thank you very much. There's a slight change to the program. Just to confirm that Theodor Thyssen from Russia is not here. Good. We're moving therefore back to Keki Turel for his second speech. Then will be Selçuk Peker. Is he here? And then after that will be Slavko Juraskovic. Is he here? After that, Barankov Sakirov. And finally, Lakicevic. Thank you. All of those talks will be 15 minutes, including questions.
Fortunately, I don't have any videos for this, so thank you. So, complication avoidance in spine trauma. As I mentioned earlier on, complication is a secondary disease or condition which makes an already existing one worse, and something more intricate, difficult, or confusing, an unfavorable evolution or consequence of a disease or health condition or therapy. Every medical field has complications, but those in neurosurgery can be devastating It's an unfortunate part of surgery, making the consequences worse than the original disease. So we will talk about this at the second ICCN in January. I'm asked to talk on spinal cord injury. And as you can see from this slide, the number of specialties that are involved in the management of spinal cord injury and the amount of issues that are concerned with spinal cord injury. The ancient Egyptians recognized the futility of treating a dislocated cervical vertebra with associated quadriplegia, and they mention in their papyrus an ailment not to be treated. It's truly a devastating injury with profound consequences to the individual, to his family, and to society. After a skull fracture, the severity of disability is estimated at 43%. Following spinal cord injury, it is estimated at 72%. The adage, prevention is better than cure, is true to most medical conditions, but understood only after disease strikes, and spinal cord injury is really the cruelest of them all. Injury to the spinal column or cord. So the spinal cord injury causes paralysis. Spinal column injury may or may not be associated with cord injury. However, it is prudent to assume that a spinal cord injury and immobilizing the spine till an expert in the hospital rules it out. Therefore, people with a spinal cord injury are 2 to 5 times more likely to die prematurely than people with a spinal cord injury, and some with worse survival rates in low and middle class groups. The annual incidence of traumatic cord injury in my country, in India, is approximately 10,000 new cases per year. The mechanism of injury is mostly related to motor vehicle accidents and falls, and maximum mobility is the cervical spine, and therefore that is the one which suffers the most in more than 50%. And patients do have concomitant injuries to other parts of the body. So this is a collage to show how a variety of sports injuries can produce a spinal cord injury, apart from motor vehicle accidents. Classically, it is a disease of young males. Recent studies depict a bimodal age distribution. That means the first peak in young adults and the second in the elderly group over the age of 65. Life expectancy is lower than the general population, and the average lifetime cost for a young adult with significant tetraplegia is over $4 million. A common car accident injury like this, what you are seeing, is a whiplash injury, and the damage can be from nothing to most devastating injury to the spinal cord. And this is the exact mechanism during which a vehicle which is moving forward produces a whiplash injury to the neck and to the torso. So traumatic spine injury, the immediate evaluation with a suspected spine injury is no different from any other trauma patient. And as long as the most important thing is that you must presume that the spine is injured, and therefore immobilization of spine is maintained. Spine immobilization and maintaining precautions, maintaining the BP over 90 millimeters, administering supplemental oxygen, especially if the SpO2 is less than 92%. Consider early intubation for failure of ventilation. Do not assume neurogenic shock if there is hypotension. You presume that there is a spinal cord injury. So the first responders have the greatest responsibility. When a drunken driver meets with an accident, he has a head injury, but you must not presume that it's only the head. Paramedics have to examine the victim at the same time and apply a cervical collar even before moving the patient from the accident spot, shift him on a spinal board, bring him into the ambulance, and drive him quickly. The main focus, of course, should always be to prevent further spinal cord injury. And therefore, a quick ambulation is very important. Air ambulance can be very useful in lifting these victims within the golden hour, as in a head injury. So the same rule applies. Time is brain, and spine, you must remember, is only an extension of the brain. So spinal motion restriction are very important. Maintain spinal precautions and change to Philadelphia or Miami collar, and follow. This is most important to prevent further injury, and therefore avoiding complications by following the ABCs of airway, breathing, and circulation. Remember, airway is most important. even when you see this obvious thing, you require a good airway and spinal motion restriction, whether the patient is suspected or confirmed to have C-spine injury. Intubation can be intimidating due to the concern of worsening their injuries with any small motion, and should go to a senior level care provider and not to a young resident doctor. So it's very important for this intubation to be done accurately and carefully, and preferably by a senior person. So airway, the high risk of loss of airway can be because of neck edema, hematoma, and local bleeding. As you can see over here, then prevertebral hematoma, you can see the prevertebral shadow. High cervical spinal injury, C3 to C5, produces diaphragmatic, loss of diaphragmatic function and loss of chest and abdominal wall strength. So you assess the airway, and the indications for intubation is very important in traumatic spinal injury. There are some absolute indications, like complete traumatic spinal injury above C5 level is a clear indication. When there is respiratory distress, when there is hypoxemia, despite adequate attempts at oxygenation, so you have severe respiratory acidosis. These are absolute indications for intubation. Relatively speaking, you may intubate or not, depending on the patient's shortness of breath, development of quad breathing, and vital capacity less than 10 ml per kilogram. Consideration should be given, of course, when there is a need to travel from, from the site of accident to various other facilities. So all patients with a complete cervical spinal cord injury above sea level should be intubated as soon as possible. So that is a rule. Patients with incomplete or lower spinal cord injuries will have a higher degree of variability. But when in doubt, it's better to intubate and do it electively rather than doing it when the patient is already hypoxemic. And generally for non-urgent intubations, you prefer awake fiber optic approach by an experienced provider, which helps to minimize movement and allows for a better neurological examination after intubation. So you must remember the chance of worsening a C-spine injury fracture during direct laryngoscopy is 1 in 1,000. Chance of worsening a C-spine fracture, worsening the fracture, is just 1 in 1,000. But chance of poor neurologic function, if the airway is not secured, is 1 in 1. So what should you be doing? So patients with, in the setting of an emergency intubation, there is a chance of worsening their C-spine fixation with rapid sequence intubation. So video laryngoscopy, especially to patients who are not supposed to hyperextend the neck. In general, it takes 4 people to properly intubate the patient. Can you imagine that? And succinate choline is safe to use in the first 48 hours from injury. Remember, atropine should be readily available for reversal of severe bradycardia. So that's all about airway. Something about breathing, about ABCs, breathing. So patients with cervical injury are at a high risk of respiratory failure due to, again, the same thing, loss of diaphragm and chest ventilation, loss of ability to generate an effective cough and clear secretions, aspiration and retention of secretions, and atelectasis. So after assessing the airway, you provide supplemental oxygen. Patients with polytrauma may have concomitant pulmonary injuries. Don't forget that they have chest contusions and pneumothorax, and they also contribute to respiratory failure. And therefore, breathing has to be taken very seriously by giving supplemental oxygen. Hypoxemia is detrimental, just as in a head injury is detrimental to a spinal cord injury. The rules are the same. And this may contribute to bradycardia and unopposed vagal stimulation. Non-invasive methods of ventilation should be used with caution. So then after ABC, after A and B, we come to circulation. Circulation, maintaining blood pressure to more than 90 millimeters. And you can see several pathways which are responsible for maintaining a good circulation. Neurogenic shock with spinal injury above T4 level produces a sympathectomy, resulting in unopposed vagal tone. And this is a result of neurogenic shock. Hypotensive, warm, dry skin, bradycardia. Remember, hypovolemic shock has a cool skin. So it's opposite of neurogenic shock. Do not confuse the two. The higher and more complete the spinal injury is, more severe and refractory is the neurogenic shock. Duration from 1 to 3 weeks. Patients may develop late manifestations of neurogenic shock, which may be hours to days following injury due to progressive edema and ischemia of the cord, what we call as the ascension of the injury. The terminology spinal shock has really nothing to do with hemodynamics. So circulation is like filling the tank. The first line of therapy for neurogenic shock, as with other forms of shock, is to fill the tank, bring the BP up, because these patients are profoundly vasodilated due to loss of sympathetic tone and mean arterial pressure, therefore the goal 85 to 90 millimeters for 7 days following traumatic spine injury. So you make use of a variety of these drugs as shown in these circles. It can be dopamine, norepinephrine, and please don't forget, have a very accurate examination of the patient. Now, after ABC of treatment, you try to do the evaluation. Motor sensory levels are determined. You know already all these levels, how to be determined, motor levels and sensory levels. And then you assign the spinal cord syndromes, whether they're anterior cord, central cord, semicord or hemicord syndrome, Brown-Séquard syndrome. All these come after evaluation of your ABCs, after treatment of your ABCs. The ASIA scale, the American Spinal Injury Scale, is then made from A to E. As you know already, this is very familiar. Starting with complete, that means A means complete shock, nothing, no sensory function or no motor function in the lower sacral segment. And E means sensory and motor functions are absolutely normal. So, and then you do a secondary survey. That means complete head to toe evaluation. You take down all the spine, X-ray the entire spine. Especially if you are suspected for spine injury, you should look at the spinal column, paravertebral muscles should be examined for deformity and palpated for step-offs, for areas of focal tenderness, and for priapism. I'll show you a couple of cases now and ask you what you would do in these 3 scenarios. Patient 1. How much time do I have? Okay, we'll rush through this. There's a 34-year-old male following rollover, MVA, intoxicated and complaining of neck pain. Scenario 2 is an 82-year-old male, tripped over his dog's leash, striking his head on the curb. He complains of tingling in his hands. And patient 3, a 22-year-old male, sustained a diving accident. He complains, I can't feel anything. 3 cases. Patient 1, rollover MVA, agitated, normal vital signs, adequate ABCs, overall benign examination, no focal motor deficits. Patient 2, who tripped over the leash, he's calm and pleasant, but look at his BP. His heart rate is 62. He has adequate ABCs, but he has got decreased hand grip strength bilaterally, normal lower limbs. You can already imagine what he's having now. And patient 3 has a diving accident. He's scared, but he's cooperative, but his BP is plummeted. He's got bradycardia. He said, I can't breathe. He's appearing to be dyspneic when speaking, not moving arms or legs. Inadequate ABCs.
1 minute left.
So, age-old question in the ED. Home to image. C-spine CT. That means whether one has nexus criteria or who has got a Canadian C-spine. So to avoid unnecessary radiation exposure, patients with low or moderate, you can avoid spinal injury should undergo evaluation with a clinical decision even before imaging. So you decide what is the nexus criteria. I will jump this because we have no time. The Canadian C-spine rules you already know. And therefore, who will you image? Patient 1, rollover MVA, patient 2 who tripped, or patient 3 who has a diving accident. Patient 1, yes, he's intoxicated and dangerous mechanism. Patient 2, yes, he has got focal neurological deficit. Patient 3, yes, he has got focal neurological deficits and dangerous mechanism. So you have imaging and you order multiplanar C-spine.
Let's go to conclusion, please.
All right. So I will just jump through very quickly this imaging, 2 cases and 3 cases. All right, so treatment is questionable with steroids still. Treatment with patient 1, patient sent home. With patient 2, he's kept in the hospital and revealed stenosis but no fracture. He undergoes laminectomy. And patient 3 is a very severe spinal cord injury. He requires stabilization. I will just jump through this. Rehabilitation is important. You must remember the loss of...
Let's move to the conclusions, please.
Yes. So the conclusion is, preventive measures and rehabilitation progress go hand in hand. Look not at what you have lost, but look what you still have. And leave hospital as an economically productive and self-sufficient citizen. It involves a coordinated and integrated multidisciplinary approach. So I end again with my message for the second international meeting on complications in spine injury. Thank you very much. Thank you.
We have to swiftly move on to our next speaker, Selçuk Peker. Radiosurgery for spinal metastases.
Mr. Chairman, dear colleagues, spinal metastasis is very important for the cancer patients. Almost 40% of all cancer patients develop metastatic spinal disease, and 10 to 20% of these patients develop spinal cord compression. And spinal metastasis is the initial presentation of malignancy in 20% of the patients. And also, the spine is the most common site for skeletal metastasis. And metastatic lesions are the most common tumors of the spine. Vertebral body is affected first, and approximately 70% of the patients who die of cancer have evidence of vertebral metastasis on autopsy. So mostly the primary cancer site is breast and lung, prostate, urinary tract, and melanoma follows. The location of the metastasis is mostly thoracic area, then lumbar and cervical metastatic tumors can be seen. In the clinical presentation of the patients, most of the patients are complaining from pain. And we can see neurological deficit in 1/3 of the patients. And in some patients, because of the routine follow-up of the cancer, we can see the spinal metastasis. The goal of management in these patients is to maximize quality of life for these patients, to provide pain relief, improve or maintain neurological function, and restore or maintain the structural integrity of the spinal column. We have some treatment options for these patients. We can use steroids or bisphosphonates, chemotherapy can be done, hormonal therapy can be done. Also, we can use radiotherapy, surgery, or combination of these treatments. For many years, external beam radiotherapy became the main standard for spinal metastasis. With radiotherapy, we give a broad, unfocused energy, radiation energy, to that area. But because of this treatment, because of this radiotherapy, we can see wound healing delay, fusion delay, bone marrow suppression. It is very important because these patients are taking chemotherapy. If they have bone marrow suppression, they cannot get chemotherapy. And also myelitis can be seen due to radiotherapy. And it needs almost 2 weeks to treat the patients. And because of these negatives of radiotherapy, new modalities of radiation delivery is searched in the past. And when you look at the big series about conventional external beam radiotherapy for these tumors, for metastasis, you will see that the response to pain is low and the tumor control is low. So because of that, we had to search for other treatment for these patients. In some algorithms, you may see that this external beam radiotherapy for these patients, but mostly, it's not working, okay. But mostly today, we don't use external beam radiotherapy. Instead of that, we try to use radiosurgery. So when with external beam radiotherapy, you can see here, to a large area, you give radiation. But with radiosurgery, only to the tumoral area, you can focus to radiation. Of course, while doing or deciding to do radiosurgery, you must be sure about the stability of the spinal column. If a patient has spinal instability, you have to do something before radiation. And there are many classification systems in the literature that you can find. This is one of them. So when we come to indications of the spinal radiosurgery, there are, if there is a need of radiation for vertebral metastasis, there is an indication for radiosurgery today. But special technology and knowledge is needed. And of course, this is a teamwork. And as neurosurgeons, we should be in that team. We shouldn't leave this subject only to radiation oncologists. When you look at the literature for series of radiosurgery for spinal disease, you may see that the overall survival, if you do radiosurgery for these patients, overall survival is higher than radiotherapy. And with the large series, if you see the large series, if the patient needs surgery, and if you add radiosurgery on the surgery, the overall survival will extend more. The most important factor for local control after radiosurgery is the doses that you are giving to that area. The main constraint for the doses is, of course, spinal cord. We try to keep spinal cord to get less than 12, 13 gray. But if we try to give as much as more radiation to that area. And of course, some tumors are more responsive than others to radiation. There is a PRISM score is used by MD Anderson Cancer Center. We are co-working with them. And this is only an in-house scoring system. And with this system, you have to look at the patient's gender, female or male, Karnofsky performance status, etc. You see here the scores. And you can score the patients to poor prognosis and good prognosis, excellent prognosis. And you can see here with the poor prognosis patients, the survival will be almost only 9 months, but in other good prognosis patients, the survival will be very long. To give radiation to the spine, you have to know about this article. This is a mainstay article for spinal radiosurgery. With this article, all the area in spinal areas from cervical to lumbar are divided to some sections, all the vertebrae divided to some sections. When a patient has a tumor in the special part of the vertebra, you have to irradiate some part of that vertebra. This is a standardized system, and almost all of the spine radiosurgery centers in the world uses this chart to cover the area for spinal metastasis. And single fraction stereotactic radiosurgery, of course, is good with high dose hypofractionated radiosurgery. But if you give low doses, your success rate will be low. If a patient has a circumferentially covering the spinal cord, the tumor is circumferentially covering the spinal cord, you can use separation surgery. With separation surgery, you do release the spinal cord from the tumor, then you can use radiosurgery for these tumors. If you come to complications of radiosurgery, the most important one is vertebral compression fracture. With hypofractionated treatments, it is almost 10%. But if you give high radiation in one session, the risk can be climbed to go to 30%. So you have to be very cooperative with radiation oncology, and as neurosurgeons or as spine surgeons, if the patient needs additional surgery, you have to do it. And the myelopathy rate is very low. So I want to show you some examples. This is a patient with lung cancer. You see here, I think you see here, this PET image with high hypermetabolic area here and here. So in MR image, you see the tumors. And we covered all these three tumors in this patient. And this is the control PET of the patient. You see, this was before, and this is later. And this was before, and this is later. So you can help these patients with radiosurgery. This is another patient with lung cancer also. And this patient has only one tumor here, you see, in the corpus of the vertebrae. And you can use hypofractionated treatment, and also you can use one session treatment for this tumor, because the tumor is here is small enough. So when we come to summary, if a patient with spinal metastasis needs urgent decompression, spinal stabilization, you have to do it. If a patient needs separation surgery, we have to do it. For pain control, spinal radiosurgery works well. For tumor control, also spinal radiosurgery works well. And the result for survival is good for radiosurgery, and the complication rate is lower than radiotherapy. So radiosurgery today has replaced mostly large field radiotherapy, and it can be used primarily in selective cases or adjuvant treatment for the patients after decompression and stabilization. Thank you.
Thanks for keeping to time. Questions from the audience, please?
Just a question, how you deal with when you have fracture of compression and muscle fixation?
It's easy to make radiation with screws inside?
If a patient has instruments,
Yeah.
you, of course, for radiosurgery, spinal radiosurgery, in all patients, you should have CT. Of course, we do get MR in those patients, but mostly we trust on CT for the instrumented patients, because MR can be sometimes very difficult to see the tumoral borders.
You use gamma knife or cyber knife?
Gamma knife is only for head.
Okay.
In
You
our
don't use it,
department, we have Linac for
Okay,
these
cyber knife.
tumors. Cyber knife is a kind of Linac machine.
Again, coming back to the concept of separation surgery, for me as a spine surgeon, I try to avoid doing surgeries on patients with a short life term or short survival.
Of course.
What are the criteria for separation surgery that you give a neurosurgeon to help you with your patient?
In the literature, it's said that if you think that the patient will have more than 3 months of life, then survival, then you do it.
Yes, that's one thing. But the other, let's say, we see a lot of patients with spinal compression, pathologic compression fractures.
Yes.
How much of the spinal canal destruction that you say this needs separation surgery, or what are the other criteria you would recommend us?
For Bliski 1, you don't need separation surgery. But in 2 and 3, you may need separation surgery. It mostly depends on the clinical picture of the patient.
Thank you very much for your presentation. Clearly, it is very beneficial for metastatic lesion. I was wondering if you have any experience for using this for intramedullary small lesions.
No. Basically, no.
Why not?
Because I think the doses that you are going to give the cord will be harmful for the cord. But to do surgery before radiation is very important. For the tumors, for ependymomas or astrocytomas, you have to give the chance to the patient that for the total removal of the tumor. For example, if you could not remove the tumor out and you think that this tumor will grow in the future, then you have to do not radiosurgery, you have to do fractionated radiotherapy for those tumors.
Great. I found very interesting your classification of prism, and your classification about the choice prism, what you call prism. I invite you, if you can print a page and distribute, because I didn't find in the book of abstracts. Could be interesting. Yeah, can you do this? Just print after this and distribute in the among the audience. Okay.
But this is only in-house system, only for MD Anderson. They don't publish it.
Yeah, okay, but it could.
I'm a neurosurgeon. I don't use radiation for diffuse diffuse astrocytomas. I sent those patients to radiation oncology, and in most of those patients, they use fractionated radiotherapy. They don't do radiosurgery.
No, I understand. Thank you.
Yes.
Thank you.
Thank you.
Thank you again. Very interesting. 3 more talks to go. We move on to Slavko Juraskovic. Intraoperative neurophysiological monitoring for spinal cord tumor surgery.
It's interesting, the classification is very interesting. Because it's cool. Good selection. Because there is always much discussion in the department. Should we operate this guy or not? This could be, well, with respect to everyone, this could be an idea.
Sam treba slajd 1. Hoćete ono sve u jedan da imate. Aha, otišao na drugi ekran, evo ga mišu. Evo ga slajd 1, F5 i to vam je prezentacija. Hoćete sve u jedan.
While we're waiting, who in the audience has access to a cyberknife? Linak? Nobody.
Cyberknife, which? Do you use cyberknife?
Dear chairs, dear colleagues, I will talk about intraoperative neurophysiological monitoring for spinal cord tumor surgery. The combination of monitoring ascending and descending pathways may provide more sensitive and specific results than SCPs alone, giving immediate feedback information regarding any neurological deficit during the operation. Published by Sutter in 2007, describing the importance of monitoring not only SCPs but monitoring also corticospinal tracts in spinal cord tumors surgery. So what we usually monitor in spinal cord tumors, somatosensory evoked potentials and motor evoked potentials. Motor evoked potentials can be measured from the muscles, muscle MEPs, or from the dura, epidural MEPs or D-wave. Somatosensory evoked potential, they evaluate conduction along the posterior cord and don't give any information about the motor tracts. And what we usually monitor, usually median and tibial nerve SCPs. In SCP monitoring, significant changes are amplitude changes more than 50% and latency changes more than 10%. The problem with SCP monitoring in intramedullary tumor, they are usually lost after myelotomy, and also SCP don't correlate with postoperative motor function because they don't evaluate at all corticospinal tracts, and today we have a lot of papers telling us about the limitation of using SCPs alone. We can have preserved SCP potentials, but also after the surgery we can have neurological injury. Also, in this study by Widmeyer, he proved a high proportion of all negative cases in SCP monitoring alone. So introducing monitoring corticospinal tracts is very important in spinal cord tumor surgery. By monitoring motor evoked potentials, they can be muscle MEPs and epidural MEPs. Muscle MEPs, we have a transcranial stimulation and recording the response from the different muscles. Muscle MEPs advantages, they monitor the whole motor pathway from the cortex to the muscles. They also can identify unilateral damage, and it does not require the placement of epidural electrodes. Limitation of muscle MEPs, they are sensitive to anesthetics and muscle relaxants, and they produce muscle contractions, so we can't measure muscle MEPs continuously during the surgery. D-wave is the most important neurophysiological parameter, and D-wave we have now evidence that D-wave strongly correlates with postoperative neurological status of the patient. We also have transcranial stimulation, and we record response from the dura, from epidural electrodes. We put electrode caudal to the tumor, and usually can have control electrode cranial to the tumor. D-wave advantages, they are resistant to anesthetics and can be registered in a curarized patient. Also, it doesn't cause movements, so they don't disturb surgical actions and can be continuously updated. A limitation of, on the other side, the limitation of D-wave, it can be registered under T11 level, and it can't identify unilateral damage. Principles of muscle MEPs interpretation, this is the most important part of monitoring published by the Lattice. Prediction of motor outcome of the patient by D-wave and muscle MEPs. We can see that if D-wave and muscle MEPs are unchanged, the patient will be also neurologically unchanged. But if D-wave are unchanged or decreases 30 to 50%, and muscle MEPs are preserved or lost, the patient will have a temporary motor deficit, and probably they will recover after the surgery. But the critical moment is when D-wave decreases more than 50% and muscle MEPs disappear bilaterally. The patient will have permanent motor motor deficit. So when muscle MEPs disappear and D-wave decreases under 50%, we must stop the surgery and make corrective measures, wash with saline solution, induce hypertension, and wait for 15 or 20 minutes. And usually after these corrective measures, the potentials recover. And we can go on with surgery, but if potential didn't recover after all corrective measures, we must stop the surgery. Value of intraoperative monitoring. Today we have good evidence that monitoring in spinal cord tumor surgery can predict neurological status after the surgery, but we don't have class 1 evidence that monitoring can prevent neurological injury during the surgery. We have only class 2 and class 3 evidence, and usually that studies are limited to historical control groups, like this study published by Sala in 2006. He compared two groups, 50 patients with intramedullary tumor operated with monitoring, and historical control group, 50 patients with intramedullary tumor operated without monitoring. And they compared motor outcome between two groups, and they found significantly improved outcome in monitoring group on 3 months follow-up. And they really proved that monitoring can prevent neurological injury during the intramedullary tumors surgery. This is another study published by Sutter in 2007. He showed that sensitivity of monitoring is 92% and specificity is 99%. I can say at the end that even we today don't have class 1 evidence about the efficiency of monitoring. We have a lot of paper telling us that monitoring can prevent neurological injury, so if you have possibility to use it, it is highly recommended. Thank you.
Thank you. Excellent timekeeping and clear message. Questions, please?
Just one comment and one question.
Okay.
One comment and one question. For the SSEPs, when I'm working on the dorsal column or even working on the spinal cord for tumors, I evaluate them a little bit higher because I freak out about a patient ability to walk and balance after that. So if they drop like 30%, I treat them exactly like MEPs or D waves, and I stop, optimize everything with anesthesia, optimize the mean arterial pressure. What's your comment on that? The other thing, do you measure sphincteric electric activities during surgery, or you don't use that?
Please repeat the second question.
Second question, how about the sphincteric activity? Do you do anything for the sphincters measurement?
Well, I must say I am not an expert in monitoring. I am a neurosurgeon too, and gives some evidence-based data by the literature. Well, usually you can stop with surgery even in SEP are disappeared, Also in muscle MEPs, when they disappear, it is recommended to stop or to go to different side of the tumor to change your plane, and usually they will recover. They will recover.
May I have a question? If you have a limited benign tumor like a cavernous angioma of the spinal cord and you lose your D wave, why should you stop surgery? Because you know that first surgery is the best opportunity you have. If you stop surgery, you will have a scar, the necessity to go back. I don't think it is a good idea. It is something which is lost. You must take into account, but when you are here, you have to remove.
Yes.
Of course, if you have a different tumor, like a malignant or a bone tumor, something which you will probably leave in place anyway at the end of your surgery. But if you have a very benign and limited one, I think you should go on.
Okay, but usually it is enough to stop surgery for 15 minutes and the D wave will recover. But if you don't have blood pressure, yes, induced hypertension, and D wave will recover. But if there are not recovery of D wave, usually there are some problems.
Yes, please.
This is a gray zone between surgeons and neurophysiologists as usual. Would you stop or proceed? Depends, I think, on your personal experience. We have some colleagues, they're doing a scoliosis surgery, evoked potentials drop to the ground, they stop surgery, and the patient comes out moving his limbs. So even though they checked everything technically and monitoring everything, blood pressure, and everything is okay. So I believe this is the dilemma that we need to work on and improve. So match each other's expectations from surgery.
Great, thank you very much.
Thank you.
May we move forward with Dr. Zakirov, please, from Russia. The title is Results of Surgical Treatment of Cavernous Malformations of the Spinal Cord. Which is what you just asked for. You just asked for that.
Dear Chairman, colleagues, I present the spinal department of Burdenka Neurosurgical Institute. We want to share with you our experience of surgical treatment of cavernous malformation. There are well circumscribed lesions that consist of closely pent capillary-like vessels without intervening neural tissue. Cavernous malformations of spinal cord are very rare and reach from 5 to 8% of all intramedullary spinal cord tumors. The most often localization in the spinal cord on the thoracic level. It is characteristic with asymptomatic disease, acceleration of neurological symptoms associated with hemorrhage. Risk of first hemorrhage is 1.6% per year. Due to literature review, risk of repeat hemorrhage is dramatical here and reach 66%. Disease is more common from women and rhymes mean age at 39 years old. Due to McCormick classification, cavernous malformation occupies third place by their frequency. There are 4 types of cavernous malformation due to MRI Zabramsky classifications. On slide you can see the macroscopic characteristics of cavernous malformations. And due to histology pictures, there are 3 types of cavernomas. Most often clinical symptoms of sensory disorders and pain. The most sensitive diagnostic test is MRI with SWAN and 3D merge images. It characterized with no contrast accumulation on T1 and accumulation of hemosiderin in the surrounding tissues. Analyzing the literature, we found 2 big series with 67 and 53 patients. During the period from 2002, we operated 56 patients of BICE of our department. The diagrams illustrated that the majority of patients from 30 to 39 years old. The microsurgical technique of cavernoma removal implies evacuation of hematoma and resection malformation. Resection of during veins and the change brain tissue. After hemorrhage can lead to neurological deficit. We used neuromonitoring intraoperatively in all patients. Clinical case 1, with cavernomas malformation on T5 level. You can see stages of removal. After during incision, we can see cavernoma with gliosis area. Using standard microsurgical techniques, we evacuation hemorrhage on the cranial and caudal pole of cavernoma. After that, cavernoma slightly separates from surrounding tissue and totally remove it. After hemostase, we sutured pia mater. Another clinic case with cavernoma on C5, C7 level. The same stage, starting from hematoma. And fragmental removal of cavernoma. With MRI control. Here you can see our result. According to McCormick scale, in both groups, there was worsening of neurological symptoms. There are quite often complications after this surgery, and this is rare complications. In conclusion, we can say that the surgical treatment of cavernous malformation with hemorrhage is necessary after patient's recovery. and surgical of cavernomas with hemorrhage are but the non-hemorrhage, non-cavernoma surgery. Thank you for attention.
Okay. Thank you very much. Are you running away from questions? Okay, then. That was successful. So let's move on then to spinal cord tumors in Montenegro by Novak Lakicevic, to be presented by Slavko Juraskovic. After this talk, there's a 15-minute break. Obviously, the schedule has been shifted, but there will be a 15-minute coffee break and then back for the oral presentations.
Dr. Novak Lakicevic is not here, so I will present this topic, spinal cord tumors, our experience in a clinical center of Montenegro. Spinal tumors represent 50% of all primary CNS tumors. Their incidence ranges from 0.4 to 1.4 per 100,000 people. As you all know, there are three types of spinal tumors: extradural 55%, intradural extramedullary 40%, and intramedullary tumors 5%. Extradural tumors, the most of them are metastatic, while primary tumors in this compartment are very rare. This is the list of primary tumors. Intradural extramedullary tumors, the most of them, as you all know, are meningiomas and neuromas, together 55%. After them comes filium terminale ependymoma, and this is other rare tumors intradurally. Intramedullary tumors, the most of them are ependymoma and astrocytoma, together 60%, while other tumors are rare. Also, intramedullary we can have in non-tumorous lesions like multiple sclerosis plaques, infections, and sarcoidosis. Our study in clinical center of Montenegro included 61 patients with spinal cord tumors treated between 2000 and 2018. I must mention that our population is about 650,000 people. Of 61 tumors, 12% were extradural, 75% were intradural extramedullary, and 30% intramedullary. And I must say that epidural metastases were not included in this study, except 2 sporadic cases. Extradural tumors, we have 7 cases, 2 metastases, 1 chondroma, 1 chordoma, 1 meningioma, schwannoma, and spinal angiolipoma. Intradural extramedullary tumors comprises 75%, the most frequent meningioma 54%, schwannoma 30%, and ependymoma 9%. Intramedullary tumors comprises 13%. The most of them was ependymoma, 4 cases. Only 1 pilocytic astrocytoma, 1 arachnoid cyst, 1 metastasis, and 1 neuroenteric cyst. Meningioma was the most frequent tumor. What is characteristic for meningiomas, much more frequent in females than males, female to male ratio of 5.5. And also the most frequent location for meningiomas, thoracic level, 69%. Schwannomas comprises 26%, only one was extradural, female 60% and male 40%. This is distribution by the level. And ependymoma, we have 8 cases of ependymomas. They were much more frequent in males than females. 4 grade 1, 4 grade 2, filium terminally ependymoma 4 cases and 4 cases intramedullary. This is some cases from our study. Case 1, male, 64-year-old with progressive back pain and left leg pain, and also with left femoral weakness. On MR images, we can see this tumor mass on the level L3 attached to the vertebral body. This is T2 images, one hyperintense mass extradurally on the level L3. We performed L3 laminectomy. The tumor was totally extradural, attached to the vertebral body surrounding radix L3, and we performed a radical resection of the tumor. On histopathology, it was chondroma. The patient was significantly better after the surgery, and this is postoperative MR after 5 years. I must say that in chondromas it is described that rarely they can have malignant alteration. So MR follow-up is recommended in chondromas. Case 2, male, 50-year-old with numbness on the right side, also abnormal warm and cold sensation on the right side, and gait disturbances. MR images show this intramedullary tumor on the level C2, C3. Treatment, C3 hemilaminectomy on the left side and total tumor resection, and as you can see on histology, it was pilocytic astrocytoma. This is MR images after 1 year. The patient was in good condition. Walked independently and had only discrete left hemiparesis. Case 3, male, 58-year-old with back pain spreading in the left thigh, discrete femoral weakness, MR images, this intradural tumor on the level L2. This is intraoperative picture, and we performed total tumor removal. And on histology, it was ependymoma grade 1. This is MR images after 1 year. Thank you. Thank you.
Thank you very much. Any questions from anyone?
I want to ask you one question. Do you collect all patients with spinal tumors in one center?
Well, these tumors, yes, not only one center, we have one more center in our country, and that tumors were not collected, but almost all cases, because we are the main institution, and all cases, some of the cases were not treated in our department, but in Belgrade, in Serbia, were treated. And it is almost some kind of population study, but not all tumors were included, and also epidural metastases are not treated by a neurosurgeon in our department.
Thank you very much. Thank you to all the speakers, the audience, and the co-chairman. Thank you. Enjoy the coffee break and say hi to the sponsors who are paying for your dinner tonight.
First of all, I want to introduce myself. This is Mustafa Öden, and I am coming from Kırıkkale University, which is very close to Ankara, the capital city of Turkey. We have performed a study of spondylodicitis, and I will be presenting you this study in a brief way. This is a still serious problem for the patients and the country economy today. The instance of spondylodicitis range from 0.2 to 2.4 per 100,000 patients per year. Staph aureus is the predominant pathogen, accounting for half of non-tuberculosis case. The cost of treatment to be bone and joint infection are driven primarily by the period of hospital stay. Many of these infections will require treatment with prolonged periods of parenteral antibiotic therapy. To evaluate the laboratory finding and hospital costs, each patient who were diagnosed with cystitis had been treated and discharged between 2015 and 2018 were included to this study. All patient age, gender, type of surgical intervention, date of his attempt, biopsy of infected tissue, accompanying morbidities, total hospital stay, and reproducible microorganism tips were recorded. Additionally, the biochemical laboratory findings measured on the first admission to the hospital and before discharge from the hospital were also recorded. In these 8 patients, mean hospital stay was found 35 days. Mean intravenous treatment duration was found 14 days. Total antibiotic cost was found $17,000. And also additional problems of this with patients were found as following. Psychiatric problems may develop in patients who have been hospitalized for a long time. 5 of the 8 patients had to use antidepressant pill, long-term bed occupation in the clinic, and negative emotional effects on other patients hospitalized for spinal surgery. At the end of this study, it was concluded that cystitis is not an uncommon complication. Its treatment can be difficult and long-lasting. Its cost can be high for patients and country. Thank you for listening.
It was clear and short. Thank you. Any question? Thank you. That was very short and clear. You want to invite Mr. Rahman from Bangladesh? You're here. So Mr. Rahman, Bashir Rahman will talk about the transcorporeal anterior cervical microforaminotomy, a motion-preserving surgery in pure brachialgia. Please.
Thank you. Honorable chairpersons, distinguished guests, my senior and junior colleagues, good afternoon. The topic of discussion is transcorporeal anterocervical microforaminotomy, a motion-preserving surgery in brachialgia. In introduction, I like to tell some history. In 1968, many authors tried to do anterior microforaminotomy, but it was believed that they were still removing a part of or whole of the disc to achieve fusion. Professor Zhou in 1996 was first done a transalcal approach, that is true anterior cervical microforaminotomy. Professor Saringer and later by Zhou in 2002 done this modified transcorporeal anterior cervical microforaminotomy. Material out of 32 patients which were observed prospectively, of which 22 were male and 10 were female. A single prospective study of transcorporeal anterior cervical microforaminotomy was analyzed in a private hospital in Dhaka, Bangladesh. Patient having pure brachialgia who are not relieved by conservative treatment for more than 4 to 6 weeks was included in the study. And a patient having multi-level disease, bilateral involvement, and spinal canal stenosis were not considered in the study. A procedure, surgical approach is made from affected site similar to the conventional anterior cervical discectomy, except that a 3 to 4 centimeter transverse skin incision is made and one level higher than the affected disc level. That is, for cervical 5-6 level, the skin incision should be over C4-5 level. A sharp and blunt dissection through various layers of the disc cervical fascia was carried out. Prevertebral fascia was opened. The midline on anterior surface of the upper vertebral body was marked by C-arm in relation to 2 longus colli muscles, and then longus colli was dissected subperiosteally with bipolar cautery and self-retaining retractor was placed. A portion of drill hole was made 4 to 6 millimeter above the lower vertebral border at the inferior portion of the upper vertebra. A 5 to 6 millimeter drill hole is made from medial to lateral direction so as to open the foramen, avoiding damage to the medial wall of the transverse foramen and underlying end plate. After drilling the vertebral body at its end of the microforaminectomy hole, microcurette and microhook can be used to breach the posterior longitudinal ligament. An extruded portion of the disc was then removed by microhook and microronger. The adequacy of foraminal decompression is checked by blunt hook, and CSF pulsation can be seen at the end of the procedure. This is the case, a 50-year male having a typically laterally prolapsing disc with severe brachialgia, which were not relieved by conservative treatment. You can see the C6-7 on the right side. This is the sagittal T2 section and the coronal one. This is the transverse section along with a CT scan of cervical spine. There is a soft disc, and this is after the procedure. A hole can be seen in the upper vertebral body. This is the transverse cut of that is axial section CT scan, which you can see the hole, and this is the video. You can see the hole is done by drill at the infiltratal part of the upper cervical vertebra, just about 3 to 4 millimeter above the end plate, and it's directed from medial to lateral direction so as there could be just at the medial end of the foramen, and after reaching the posterior longitudinal ligament, it can be breached by blunt hook. And you can see some of the discs are coming, but still it will not breach the medial part of the foramen, and after doing that, you can see the whole disc has come out, which was protruded, and the CSF pulsation along with dura mater can be seen. Okay, adequacy can be checked by microhook again for remnants. Out of 32 patients, results were immediate relief of pain was observed in all patients, while 2 patients' complaints of recurrent pain after few months indicates incomplete evacuation of the disc or recurrent disc extrusion and needed antecervical discectomy and fusion. In discussion, this approach addresses directly to the prolapsed disc in contrast to posterior laminoforaminectomy, which may partially damage the facet joint, hence the stability. In transuncal approach, chance of vertebral injury is there, and the disc height reduction may alter the motion segment as well. Some authors suggest not to cut the longus colli muscle transversely, which may cause Horner syndrome due to sympathetic injury. In conclusion, this approach is simple, safe, effective procedure for the treatment of cervical radiculopathy. It's a motion preserving surgery, minimally invasive surgery. as well, and a long-term assessment and longer series is needed to judge the potential and benefits of the technique. Thank you for patient sharing.
Thank you. Any question? I have a comment. Who started with this approach? It's your original idea, or you saw that somewhere?
I have a training in India.
In India?
India, yeah.
What do you think it's most important benefit from this?
Benefit is, as I said, in true or transankle approach, there is chance of vertebral injury, disc height reduction, and as well as motion preservation may incomplete. But this, once you go through the upper part of the body and reaching the postmenopausal ligament and relieving only just the disc portion, it will help.
But you have to select the patient.
Yeah, that is very
young
important.
Patient with extrusion,
yeah,
just
extrusion.
sequestrectomy.
Yes.
Dude, okay.
Yes.
So interesting. Let me see. Thank you.
Thank you.
Next speaker is Mr. Attia from Saudi Arabia. You're here. He will talk about the role of O-arm and neuronavigation in the management of cuffless spine surgery case.
Yes, sir. Thank you very much. Good afternoon, everybody. I'm Walid Attia, and I'm proudly serving our people in Saudi Arabia and Egypt as well. This is my team, and I cannot do this job without this well-balanced team. And as you see, as surgeons, we're pretty much split between orthopedics and neurosurgeons, so we don't pretty much fight. And all the assisting teams, we are blessed to have a person from every specialty that could help in the OR. Apart from me being a consultant for Medtronic at the time of that study, we have no other disclosures. As you all know that the type and extent of surgeries carried out for complex spine disorders lacks the evidence-based medical proof. It is up to the healthcare provider, sound judgment and expertise to do what is needed for the patient. A lot of surgical challenges, which are not limited to decompression near vital, vascular or neural structures, decompression at a blind angle, and sometimes difficult trajectories for instrumentation. In our hands, we found that the intraoperative CT quality O-arm and the neuronavigation, which are still under investigation as aiding tools in such operative modalities, but helped us a lot. In between the years of 2008 and 2017, we studied a big group of patients, about 110, using Medtronic O-arm and stealth station. Preoperative CT and MRIs are useful on small scale, but intraoperative O-arm 3D images was the main burden during the surgery. Our cases included some traumatic spinal fracture, dislocations, infective, inflammatory, benign, and malignant neoplasms as well. All had technical challenges regarding adequacy of compression and safety of instrumentation, and the combination of decompression and instrumentation of different modalities have been done. This is our first case. 14-year-old male had an RTA 5 months before presentation. He was neglected at a peripheral hospital and neurologically intact. This is the image as you see here, the CT on the right side and MRI on the left side. You can just see how bad the spinal cord is compressed. Axial cuts, and the guy was blessed enough to have the cord swifting away from the dents. So he didn't have any neural injury. We thought at the beginning when they saw that CT that there is some sort of fusion between C1 and C2 in that place. And as usual, we prioritize what we need to do. Is it decompression, correction of deformity, with keeping in mind that might have a flail dents, and the instability itself. The routes of treating that, would we go anterior, would we go posterior, would we go combined? Which way to start, anterior or posterior? Doing our homework, taking the measures, as you see here, for the C1 and C2 screw trajectories. And just in case if C1, C2 fusion wouldn't work, we just take our measures to see occipital-cervical fusion. Again, with the CTA, checking the places of and integrity of the verts. This is intraoperative neuronavigation image to show you what the screw trajectories, and I would like you to focus on the lower lower right hand image. This is the place where we took the C1 arch away, and I used the sonopet trying to take the dents as much as I see. I took about 1/3 of it, but I'm checking. I had to stop because, you know, I didn't feel comfortable to continue. This is the trajectory for the screws, and we fixed him at that stage, partially corrected, and he did well. This case was studied presented with published with other studies in this article published in Asian Spine Journal in 2012. More difficult case, lumbar spine with oncology and deformity. She's 16 years old female with destructive lesion at number 5. 2 years prior to admission to our hospital, she was operated upon with posterior lumbar decompression and fusion, biopsied. They did lumbar 2 to sacral 2 fusion. They confirmed the diagnosis of giant cell tumor of the spine. She fell down after the surgery and S1 screws broke. She got infected, revised for hardware removal 2 months down the road, got infection treated, and then refused with the same levels, complicated by sacral screws penetrating the lumbosacral plexus, paraplegic and incontinent at that stage. Her father was a little bit anxious, and he abandoned radiotherapy after only 9 sessions of hair radiation. She was on narcotics for 1.7 years before she was presented to our hospital. She was bedridden for about 2 years at presentation, infected wound in the back with pus discharging sinus. Neurologically, she was, lower limb was 2/5 in the major groups, except the bilateral 0/5 around the ankles. She had double sphincteric incontinence at that time. CT, as you see, an MRI showing the breakage of the screws and the screws that they had at that time. 3D reconstruction, and it shows the amount of protruding screws into her lumbosacral plexus at that time. Again, MRI showing the remnant tumor. As usual, we do list the problems: the expanding tumor insufficiently treated, infected and broken hardware, the deformity and instability, wound healing after repeated surgeries, dose of radiotherapy that we need to complete, and the narcotics abuse. We take care of the surgical parts and leave the medical parts to the other teams to take care of. Again, putting priorities, we need to do decompression and mass resection. We need to move the hardware, broken or infected, to correct the deformity and achieve stability. The routes again, would we go anterior, would we go posterior, combined, and which way we start with, and this is the actual scenario. We started posteriorly, did decompression of the epidural component, we took the hardware out, and we had an accident at that time. I found the anesthesia screaming, stating that the patient is in hypotension. We had to stop, bring in the ultrasonographer in the room and the vascular team. They checked everything and nothing was wrong with the patient. And that was the doomed screw that we thought on removing it, it had injured some vascular structure. The other stage 2, we took her from anterior, and we just managed to take the parts of the tumor as much as we can and put a cage. It's not ideal, I see, but it did well in that stage. If you see on the right-hand side, part of the tumor with the calcified cortex, we thought we could just take part of it anteriorly, but we couldn't do that. And that's the technical video clip. Okay, the head of the patient is on the right side, as you see. Now digging around the remnants of the screws as we managed to see them with the navigation. Taking them, this is one of the broken screws, as you see. It's totally embedded in bone. Digging under the thecal sac, taking the remnants of the tumor, as you see here. At stage 2, again, the head of the patient is on the right side, in the left side. Vascular team moved the vessels pretty well. We're digging in between the vertebra and taking the tumor, as you see, piece by piece. And this is the old cage. We don't have an instrument to take it out, but it is a little bit tricky. Again, priming the end plate after we removed big part of the tumor, as you see here, working in between these big anacondas, if we can say, trying to put the cage, but we found it's a little bit tight for it after packing. and we needed just to remeasure to make sure that everything is in place, and we needed some distractions. Putting the pens, these are the cervical pens, but it worked well. Sometimes, as you see here, it is difficult to put the pen under the vessel, and we had to go above the vessel and do distraction and retraction of the vessel to put the cage. Again, proper mobilization was done by our vascular team, and that was a blessing that we could just achieve that. Protecting the vessels, as you see with the spatulas, is very important here. Again, we were unable to retrieve the right-sided S1 screw. It was near iliac vessels, that the screw that caused the problem for the first surgery, and we were unable to attack the paraspinal tissue. It was so deep for us. Again, we went posteriorly. The seroma and the wound were taken out. We stat gram stain and revealed infection. We aborted instrumentation, but we managed to excise a little bit of the remnant spinal mass around at that time. Again, if you see on the lower right and lower left corner, this is part of the tumor, and with the navigation, because the tumor is calcified, we could reach to the cortex itself and remove big part of it. Problem, on closure, there was insufficient muscle fascia and skin to close the wound, so we got the plastic team to close it. The final posterior stage, we guided by neuronavigation and intraoperative CT quality images. We managed to put L2 to S2 pedicle screws with bilateral iliac screws. We rechecked on the paraspinal contrast enhanced soft mass with the calcified shell, removed big part of it, and plastic surgeons closed the wound. The problem was the S1 screw that we didn't take out. It was in the trajectory, so neuronavigating was a little bit helpful just to sway away from the trajectory of that screw. This is the final image, as you see. Medical problems taken care of by the medical team. Intraoperative image guidance, the O-arm and 3D CT quality of it, and neuronavigation was very helpful in our hands. The 3D CT images of the O-arm are still of low quality, so that's a trick we need just to take care of. The merits of that is the axial cuts, the real-time trajectory all the time, the intraoperative CT quality to make sure that everything in place, less exposure to ionic radiation for your team, and confidence to approach in difficult areas. This is a video clip showing the screws in place after we did, and here you will see the cage in place in a minute. Okay, and the iliac screws and the sacral screws also. I need just 30 seconds.
Okay.
Less exposure to ionic radiation, and here I just need to refer to the dosimetry report by Medtronic O-arm. The irradiation pattern is a butterfly irradiation pattern, not like the C-arm. So better to hide behind the body of the O-arm for the ones who are using that, or the technician himself. That reduces the irradiation to that operator himself. Again, the problems are the dose of radiation, the artifacts, respiratory and instrumentation movements of the patient. Anatomical orientation sometimes is difficult if you put the patient in the deformity position, the image quality, and for obese patients. But the combination is very useful for us. There is a learning curve, but you will comfortably catch in a short time. When in doubt, you must trust what you see, not what the machine sees. You have to go anatomical, consider your scanning, and if image quality is not satisfactory, go back to the C-arm. Thank you very much, and please contact me with these contacts if you need to share your information with me. Thank you, I appreciate it.
Thank you, nice lecture, very clear. I just want to ask you something, but you already mentioned those, what I want to see and ask you, so thank you, that's clear.
Thank you.
Any question from the floor? 1 minute, one question. So as you said, it's not for every case, for every T-leaf, P-leaf surgery, but just for the to preserve the patient and anatomy very important, and what we see from our eyes and our brain, and we have to learn the young people to operate without.
Definitely, yes, this is definite.
Not start with O-arm and neuronavigation, but
start traditional and then upgrade.
I agree. Thank you. Nice lecture. Next speaker is Mr. Ivetic from Serbia. You're here. Okay, he will give us a lecture about the predictors of surgical outcome in cervical spondylotic myelopathy. Please.
Dear colleagues, dear chairmen, I am Dr. Dražan Ivetic from Department of Neurosurgery in Military Medical Academy in Belgrade. The issue of these topics is predictors of surgical outcome in cervical spondylotic myelopathy. Cervical spondylotic myelopathy is a progressive degenerative disease that results in a compression of the cervical spinal cord, leading to neurological dysfunction. CSM is the most common form of spinal cord dysfunction. The word myelopathy comes from two Greek words, myelos, meaning spinal cord, and pathos, meaning disorder of. Some historical data: Horsley in 1892 performed first surgical interventions for CSM. That was C6 laminectomy, and 1 year after treatment, patient had full recovery. Sperling and Scoville in 1940 performed first foraminal decompression. After that, Robinson and Smith in 1955 and Clovard in 1958 described anterior cervical discectomy and fusion. That was a true revolution in cervical spine surgery. After that, Bailey and Begley in 1960 published their paper about only strut grafting after corpectomy, and Hirabayashi in 1983 introduced open-door laminoplasty. The disease is more prevalent in males than in females. 13% of males in age 30 have radiographic evidence of disc degeneration. In age 70, that changes are present in 100%. In females with age 40, 5% have radiographic evidence of disc degeneration, and in age 70, this percent is 96%. In a recent study, Bogarts and Bartels reported that the annual incidence of patients with CSM treated surgically is 1.6 per 100,000 inhabitants, but the actual incidence and prevalence remain unclear. Degeneration of the cervical spine over time encompasses a set of anatomical changes that can result in reduction of spinal canal, cervical spine instability, changes in sagittal alignment, and consequently myelopathy. It is clear, we know that the disc degeneration is the initial event in disc degeneration. Over time, that process involves all components of one spinal segment and usually more than one level. Cervical spondylotic myelopathy presents insidiously by clinical symptoms and signs. Symptoms are gait instability, braided dysfunction, and fine finger motor difficulties. Signs are hyperreflexia, Hoffman's sign, ankle clonus, spasticity, and so on. Many controversies exist regarding the optimal management and the outcomes of surgical treatment of patients with cervical spondylotic myelopathy. Although a number of studies have shown improved neurological outcomes in patients with severe neurological deficits who receive surgical treatment, the effects of surgery on the full spectrum of the CSM cases remains in question. Now we would like to present our data. The research was conducted in Department of Neurosurgery in Medical Military Academy. The research protocol was approved by the Hospital Research and Ethics Committee. A total of 59 consecutive patients with CSM were prospectively recruited for this study. 9 patients were excluded from study according to medical contraindications, loss of follow-up, and exclusion criteria. Subjects were 18 years or older, had symptomatic CSM, had no prior cervical spine surgery, and did not have symptomatic lumbar stenosis. Patients were treated by anterior or posterior approach at the discretion of the surgeon according to medical rules. Outcome evaluations included the MGOA score, the NURIC score, the neck disability index, preoperatively and postoperatively at 12-month follow-up, and functional recovery ratio was evaluated by using the formula of Hirabayashi. Patients were classified as having mild, moderate, or severe myelopathy based on the MGOA scores. In our study, 74% were males and 26 females. 70% were 65 or younger than 65, and 30% were older than 65. 20% of patients had one stenotic levels, 36 2, 32% 3, and forced stenotic level had 12% of patients. The most involved segment were C5, C6 with 35.6%. On the second place, C4, C5 with 32.2%. On the third place, C6, C7, and on the fourth, C3, C4. 68% had high T2 signal intensity on the magnetic resonance imaging, and 32% had normal T2 signal intensity on magnetic resonance images. The anterior surgical decompression were conducted in 56% of the patient, and posterior decompression were conducted in 44% of patient. The anterior surgical group were treated by anterior discectomy, Smith-Robinson technique, and anterior cervical anterior discectomy and fusion and fixation with anterior cervical plate. Posterior group of patients were treated by laminectomy and laminectomy and lateral mass screws. This table presents the results and statistics for the parameters, the NURIC score, the MGOA, and the neck disability index preoperatively and postoperatively. The extent of improvement in the NURIC score is statistically significant. The extent of improvement in MGOA preoperatively and postoperatively is also statistically significant, and improvement in neck disability index is statistically significant. This graphic represents the improvement in all three parameters, NURIC score, MGOA, and neck disability index, according to results from previous table. This table presents the results and statistics for parameters MGOA score. According to MGOA score, we are classified the patient in three categories. 18% of patients had mild myelopathy preoperatively, 38% had moderate myelopathy preoperatively, and 44% had severe myelopathy. The extent of improvement in all three categories of patient according to MGOA parameter is statistically significant. This graphic represents the improvement in parameters MGOA in all three categories of patient according to results from previous table. Functional recovery was calculated by using the formula of Hirabayashi. According to that formula, 46% of our patients had satisfied functional recovery, and 54% had unsatisfied functional recovery according to this formula. After that, I would like to conclude it. Patients with CSM show significant improvements in all outcome measures after operative treatment. All groups of patients according to MGOA score have benefit with surgical intervention, and surgical intervention eliminates the chances of the neurological deterioration of patient with CSM. Dear colleagues, thank you very much.
Thank you. Nice. Any question from the floor? That was clear.
Thank you very much.
Thank you. So the colleague from Bangladesh.
Do you have any prediction between the T2 hyperintensity that are showing CSM, cervical spondylitic myelopathy? You have shown some percentage of cervical spondylitic myelopathy are T2 hyperintense, and some are not.
Yes. That patient who have not T2, all patients had clinical signs of myelopathy, but not T2 signal.
Hyperintense.
Yes.
What was your message from there? Are they influencing any outcome?
Yes, this presentation is part of one large study in our department, and we have that result, but that result we will publish in article later. All these parameters are involved and analyzed.
Okay, thank you.
So you still using very much neurological examination, very detailed, basic, to say there is the myelopathy even we don't see it on D2.
Yes, clinical signs and symptoms and signs are very important in diagnostic of myelopathy.
Yes, but it's recent time. I'm not sure that everywhere we still use these neurological findings.
Yes, but
opposite to MR findings. So
yes, but you know, many patients with moderate myelopathy and severe myelopathy have no signs on MRI, hypersignal.
But you write this diagnosis that it's myelopathy on discharge letter, even you don't see it on MR.
I based my diagnosis of myelopathy on clinical signs on the first place.
Yes, sir.
I have a little comment on that. Yes, sometimes you have discrepancy between what you see in clinical and what you see in MRI. There's more and more papers coming about dynamic MRI in this area, and I think that will help a lot. Early studies, yes, but I think they'll help in this particular situation. What's your comment?
Yeah, you know, I mean, I'm asking you because in this time, you know, in the current time, we have to be, you know, to be honest, be sure that there is myelopathy. When we write that diagnosis to the patient tomorrow, he could send us to the court and ask what you did actually. Radiologist didn't solve the myelopathy, so you can say, yes, I had all the signs, clinical signs, but those clinical signs looks to be the past, unfortunately. But I support your decision. Yeah. We know that there is some neurological deficit, some signs as Hoffman, Spurling, or others, Lermit, and so that they confirm that there is happening in the medulla, not only the rear root. But you know, in 21st century, especially in United States, they want to confirm that on figures. So
especially in the case of mild myelopathy.
Yeah, especially.
That is not problem when we have severe myelopathy, and in that case we have also radiographic evidence and clinical signs. But in mild myelopathy, that is a problem.
I encourage the young colleague to be the doctor and saying, if I think it's that, you know. But we have to be careful. Yeah.
Yes.
Thank you.
Thank you.
So, Mr. Arkady, next speaker from Russia. You're here. Kazim Arkady, use of nitinol rods for fixation of the lumbar spine, prospective multi-center study. Please,
Thank you.
Mr. Arkady.
With great pleasure, I will take part in this congress here in Serbia. So my report is about nitinol rods. Why we started use? Because, as you know, rigid fixation has some complication, such as pseudoarthrosis, bone resorption, and one of the main objective of dynamic stabilization to prevent adjacent segment disease. So the creator of dynamic philosophy is Henry Graf, and two words about our nitinol rods. What is this? It's alloy of nickel and titanium, and it's have characteristics as shape memory effect, superelasticity effect, its ability to return to the initial state after deformation. Also biocompatibility, corrosion resistant, and completely biological inert material. Here you see the graphic which represents the property of superelasticity. You see that after finish of deformity, material come back in the initial state. We have some cadaveric study, and here on this graphic you see that behavior of initial state and nitinol rods is similar. In our study take part 4 clinics in Russia, 2 in Moscow, 1 in Krasnodar, 1 in Omsk. It was study period 2015-2018, single protocol and post-operative control. And I must say that this study was first multi-center study in orthopedics in Russian Federation. This here you see our rods. It's 19 rods, 5 and 5 millimeter diameter. The size and curvature of these rods were calculated from the average anatomical parameters, characteristic of the lumbar spine and lumbosacral junction. The purpose was to study the effectiveness of surgical treatment of degenerative disease of lumbosacral spine using dynamic rods with the effect of thermodynamic shape memory. The study design and perspective randomized multi-center. Inclusion criteria age from 18 till 75, degenerative spine pathology, and degenerative spondylolisthesis of the first degree. Exclusion criteria is scoliosis, sagittal imbalance, oncology history, infections, osteoporosis, some electric pacemakers or metals which make MRI not possible, and also ischemic and degenerative spondylolisthesis more than second grade. 120 patients with degenerative disease of lumbar spine, which underwent stabilization with nitinol rods, and 100 patients using titanium rods. All patients before surgery and during the follow-up period underwent the following research protocol. It's standard X-rays and functional X-rays, MRI, CT. Also we use WASH scale, SF36, and also the disability index. Here you see the study plan. In the group of patients with nitinol rods, bone autograft fusion was not performed, and in the group of titanium rods, after decompression, we perform interbody cage using TLEAF or PLEAF at level L5-S1, or if it's necessary, L4-L5, and autograft fusion. Here, graphics of our study. So we can ask that no statistically significant difference in functional scores between nitinol and rigid rods, and only average ROM was statistically better in final follow-up. And also in both cases, statistically significant changes in the questionnaire scores were noted in the postoperative period. When we studied the X-rays, we saw that the average in one segment after stabilization with nitinol rods was about 5 degrees in one segment. Very interesting was the complication associated with implants. Because in this study take part orthopedic surgeons and neurosurgeons, we have different complications in these groups. Because of in a neurosurgeon group, they fixated only 1 or 2 level lumbar spine. They have complications, one rod fracture and one screw fracture in nitinol group. And orthopedic surgeons performed also 1 and 2 level, and also more than 2 levels. And we have such complication as adjacent segment disease in 2 cases, implant instability in 1 case, and also rod fracture in 2 cases. And in titanium rods, there was adjacent segment disease 6 cases, implant instability 4 cases, and rod fracture 1 case. We have a lot of scientific work with these nitinol rods in Russian Federation. Some clinical cases. This patient, 32 years old, he is a hockey player, with degenerative of lumbosacral spine, herniation on L4, L5, L5, L1, and radicular pain syndrome. X-rays before surgery, and this is X-rays after surgery, and this is after surgery 5 years. So you see some mobility in the fixed segments. And this is MRI after 5 years of surgery. Here you see that there are no problems with the adjacent segment. And next patients with have degenerated spondylitis of L5. Also X-rays before surgery, surgery, and after surgery we also have some range of motion in the fixed segment. And CT after 4 years there is no instability of implant. So in conclusion, I must say that nitinol rods allow a small amount of movement in each fixed segment, which release stress on the pedicle screws and protect the adjacent segment from overload and associated complication. The use of nitinol rods simplifies the technique of surgical intervention, since there is no need to create a bone block in the lumbosacral spine. This lowers the traumatism duration and blood loss of the surgery. And the results of the multi-center study provided evidence of the effectiveness of this stabilization approach at 1-2 level in young and active patients. Thank you for your attention.
Thank you. Yeah, there is a question, please. Ms. Tia.
Very nice presentation, I appreciate that. What I would recommend you need a long-term study of that, because I believe the repeated stresses over the long period of that new type of rod might come out with, something that against it, I don't know. For how long did you do that study again?
This study was for 3 years, but we used these rods in our department about 7 years. And we have very good results in the young active patients, because when we perform in adult patients with osteoporosis, it was not good results.
Okay, good. But still, I think the long term will prove whether yes or no to these type of rods. How about scoliosis cases with big deformities? Do you have experience with them?
Now we have just studying these procedures, and we think about this to use these rods in the scoliosis patients.
Perfect, thank you.
Any question, others? You mentioned that we don't need in any case put anything inside. You think it's much stronger nickel titanium than titanium alone,
Yes,
so we don't need.
Yes, it's stronger, and because of its have property of superelasticity, that's after deformity, material come back in the initial state. So because of this, there is a range of motion. So if we will use some cages or bone grafting, we lose this dynamic property.
So I think that this motion preserves the breaking of the screws and allow the spine to accept the stress above and down from the level. This is explanation. Is it too expensive?
No, it's not expensive. It's
cheaper than titanium, or
it's like titanium.
Okay, interesting. Let me see. We for sure need the long-term follow-up to see what will happen in the future with these cases. Thank you.
Next speaker, Dr. Miljan Mihajlović, is here. After them, Dr. Kofi from Morocco. Not here. Dr. Mladen Karan from Serbia.
Chairmen, ladies and gentlemen, dear colleagues, before I start, just let me to express my deepest gratitude to the organizers for having this chance, for having this opportunity to give this talk in front of this eminent audience at this kind of conference. And I'm sure you're all quite tired despite your goodwill to be here and to see everything. So I'll try to be short and to tell a little bit about factors affecting outcome after lumbar disc surgery, which is probably the most common neurosurgical procedures, and a little bit about our abilities to predict outcome after this kind of surgery. So I would start with a few facts giving importance to this condition, like the very, very high prevalence of back pain during the lifetime, between 50 and 80, 90, 80, or even 90%. And the other thing is also very high lifetime incidence of sciatica, between 13 and 40%. The main cause of low back pain and leg pain is herniated lumbar disc, and fortunately for us surgeons, the majority of patients with sciatica with low back pain during the life experience positive natural course of disease, and disease have very good response to non-surgical treatment. And there are some studies who claim that 90% of sciatica attacks respond well to conservative management, which practically means that we have to intervene surgically only in maybe 10% of cases, and these are some situations when we have to perform surgery. And when we decide to do that, we have to think about many things, those famous questions, when, how, and many other factors which could affect the outcome, because the outcome is, which is most important after surgery. So when we are talking about short-term outcome and short-term results after surgical treatment of lumbar disc herniation, I think we can say that we have some kind of general consensus in the literature which says that we have a quite high success rate, between 17, 90, 95%, but during the first year after surgery. But if we talk about the long-term outcome, I can say we are not even close to that concise, that precise solutions, because these are probably three the most common cited studies which dealt with long-term outcome after lumbar disc herniation surgeries: Weber study, MLS study, and the SPORT trial. And I would like to tell a little bit more about the results of those studies. The Weber studies, it was a randomized single institution prospective study with long-term follow-up. And they assessed the outcome according to authors' assessment of patient statements of their current well-being. And this study showed greater improvement in the surgical arm after 1 year, but difference between surgical and non-surgical arm diminished after 4 years, and there were no more difference also after 10 years of the follow-up. This study is also characterized with high percent of crossover. 26% of patients pass from non-operative to operative arm during the time. And MLS study was also a great multi-center prospective observational study, also comparing operative and non-operative cohorts, this time using some standardized outcome tools and like Roland Morris scale and SF36 scale. And this study also showed better results in the surgical arm after 1 year, but in this study, that difference, statistically significant difference between two arms, maintained up to 10 years. And it was quite different, quite opposite than in a previously mentioned study. And to make things even more funny, even more complicated, the SPORT trial, also with similar design, found statistically significant difference in surgical arm for some instances, and for other parameters they followed, they they failed to found statistically significant advantages of surgical treatment. So I think we can clearly say that there is no consensus about long-term results after lumbar disc herniation surgery. And at the Clinic for Neurosurgery in Novi Sad, Clinical Center of Vojvodina, where I'm coming from, we decided to create a small retrospective study in order to analyze different factors, demographic, clinical, radiological, social, and other factors, and try to find their relation with the outcome after lumbar disc herniation surgery. We did that as a pilot for a bigger study we are planned to do in the months to come, and in years I hope to come, and to see all benefits and all flaws of our current way of treatment of those patients. So we retrieved from our database, hospital database, retrospectively, data for 99 patients which were surgically treated in our institution during 2 years period. And all of those patients had single-level unilateral discal herniation, and all of them were treated with interhemilaminotomy and microdiscectomy, always with assistance of operative microscope. We analyzed all those data we found in medical histories of our patients. I won't be able during the short time to show you all results. We also thoroughly analyzed imaging data, and we created a small convenient battery to assess shortly assess the assessment outcome of our patients. And I'll show you just the most important results we found. We had 64% of male patients, average age was almost 46 years, average duration of complaints was 146 days. You can see here the most common complaints in our group of patients. The mostly common affected level was L4, L5, followed by L5S1, and just few patients with L3-4 discal herniation. Here you can see we have quite equal distribution of degeneration of paraspinal muscles grade. And when we analyzed facet joint degeneration, we saw the vast majority of patients had grade 0 and grade 1. It was quite young group of patients without prominent spondylotic changes. And in opposite to this finding, we found quite poor condition of intervertebral disc, most of them grade 3, grade 4 of Furman scale. And how we assess the outcome? We called our patients by the phone, and you know, lately the assessment was shifted to the self-assessment, and we tried to ask our patients, how would you assess your current health condition in this moment? From 0%, the worst possible, till 100% the best possible. And little bit more than 70% of patients were satisfied with their current condition after approximately 9 months of follow-up. And we also, during that phone call, administered one short questionnaire called Hospital Anxiety and Depression Scale, trying to define is there any psychological problems in our group of patients which we failed to discover before the surgeries. And regarding anxiety, you can see there were few patients with borderline and abnormal score, but most of them had normal score. And in this questionnaire, it's very similar with depression. Only one patient was in a borderline zone. And despite having all this nice data and applying some complicated analysis, statistical analysis, practically we failed to find any significant influence of all those factors on overall outcome in our group of patients. So we concluded that we do need more studies, better studies, studies which will include larger number of patients, better design study. We have to see all those studies with all their flaws and bad things and try to correct it in the future. And all this in order to become more able to better predict the outcome and to reduce the number of patients with negative outcome and patients which are unsatisfied. Thank you for your attention.
Thank you, Dr. Karan. Question, please.
Thank you very much. Actually, you were hitting real hot topic. I believe the big problem is in the community, which does us as surgeon is the community. Thank you very much. Is the community, and it's looking for the general idea about spine surgery. I served in some communities that have a bad idea about spine surgery. If you do spine surgery, you will be paralyzed, so run away from these bastard surgeons. Some communities with high work compensation, you find, yes, a lot of the crossover from patients you do conservative. The patient is rushing to do surgeries for the work compensation or that. We did a study published 5 years ago with the conservative treatment of lumbar disc prolapse. And guess what? Not only the patient was greatly improved, but even the MRI with big chunks of discs compressing the root or the thecal sac, they go away. We don't know why. We don't know why it worked for these patients, but I believe because the general idea about the patients run away from the surgeons, they give you clear view and big time to study them to see how things are going.
I completely agree. In the study we are planning to conduct in months and years to come, that was one of the things we try to predict, and we would like to try to perform similar or practically the same study, not in a different, not in one country, but maybe in 2 or more countries in different healthcare systems, and try to avoid those social and any other biases which you mentioned. Yeah.
Any other question for Dr. Karan? Thank you.
Thank you very much.
Last speaker, Dr. Jelacha from Serbia. Surgical treatment of thoracic disc herniation case report.
Ladies and gentlemen, dear colleagues, members of the chair, I'm very glad to be here today to present our case, not the how I do it session, but how we did it. And that is the treatment of thoracic disc herniation, our way of thinking how we can solve some problem. When we consider some facts, we can see that thoracic disc herniation among all symptomatic disc herniation constitutes at the top of 4% of them, and on the same side, most of the time the treatment is conservative. When we assess the possibilities for operative treatment of thoracic disc herniation, that can be very challenging, and it depends of the anatomic location, depends of the consistency of the herniated disc, and as well of the patient functional status and the surgeon's experience. We would like to present the case of one of our patients, which is 44 years old with a progressive spastic paraparesis of the lower extremities and paresthesia below the level of T11 and axial thoracal lumbar pain. As we can see on the MRI images on the sagittal cut, we can see that the cervical spine, there is no compression of the spinal cord in the spinal canal, but in the thoracic spine we can see the sign of the myelopathy on the T10, T11 level. On the axial image, we actually see that dorsomedial herniated disc which is compressing the spinal cord, and we conducted the all possible images or diagnostics, and on the CT we can see that the most of the disc is calcified. When we consider the surgical approach for this kind of treatment for these patients, according to the literature, there are 3 ways. The posterior approach, which is actually indirect approach, only decompression, and then posterolateral approach, which is actually which is aimed to get to only to the lateral part of the spinal canal, and then the anterior or transthoracic approach, which is nowadays modified to mini thoracotomy or video-assisted minimal and invasive thoracoscopic procedures. After that, we plan the procedure, and some of the difficulties or things to think about are the patient positioning and anatomical landmarks we can use and try to determine the level when we start. Then the use of fluoroscopy, of course. Then securing the airway with the use of Carlin's dual lumen tubus. Of course, in our clinical center, we try to be multidisciplinary as we can be all the time. So we tried to, we did this operation with the aid of our thoracic surgeon. We didn't use the intraoperative neurophysiological monitoring, and we had an idea to use the autologous bone graft. The surgical procedure and the approach was, as in the literature, straightforward, and we, with use of the fluoroscopy, as I said, and the anatomical landmarks, the insertion of the diaphragm, we see the right level. We then resect the ipsilateral head of the rib and posterior vertebral part of the body, and then approach to the disc trace and the spinal canal. As we can see in this picture, that part of the spinal canal can be very hard to reach, and the surgeon must be experienced and try to not to erode the dura and severely compromise the spinal cord. The other issue is also the amount of the vertebral bone which is needed to be resected, and it's easy to get from the way you planned, and so the resection is tailored according to the part of the calcified disc. So the post-operative management of our patient was that we used the chest tube, water seal drainage for 3 days, and after that on the x-ray we follow the patient every day with the x-ray. There is no helothorax or hematothorax. We mobilize the patient early in the bed, and after that when we put out the chest tube, we mobilized in the department. We prevent the thromboembolic complications with the low-weight molecule heparin, and there was no significant postoperative wound pain or intercostal neuralgia, and we saw immediate improvement in neurological deficit. As we see on the control CT during the hospital stay of the patient, we see adequate position of our autograft from the head of the rib and fully decompressed the spinal canal. The patient was then referred for the physical treatment for 3 weeks, and after that, on the outpatient control, she had complete resolution of the spastic paraparesis. On the follow-up imaging, we can see that 12 months follow-up completely restored spinal canal, and our fusion with the part of the rib was successful, which is, according to the literature, it can be done with the pedicle screws only unilateral for the side when we approach, and even left as was not fused with anything. To conclude, we think that our anterior open transthoracic approach is not that invasive. It provides optimal ventral exposure and has been recommended in the literature. Fusion with the autograft, which is taken without significant morbidity, should be the option to think about. And we didn't find that the intraoperative neurophysiological monitoring is mandatory in this case, even though the complications can be very, very potentially very harmful. So in the front of the Clinic of Neurosurgery in Novi Sad, I would like to greet you all and say hello from the European Capital of Culture from 2021.
Thank you, Dr. Jelacha. Any question from the Audience, please, colleague.
Is it possible some comments?
Yes, yes, of course.
I have experience about thoracotomy and endoscopy surgery this hernia. Firstly, my opinion, if you have level TA10H, then better use left side because hepar and high diaphragm in the right side. Is it don't need make very big thoracotomy. Mini thoracotomy is very nice for this situation. Don't need drainage following 3 days because you don't damage lung. We stay drainage 3 days if damage lung for maybe air through lung in the chest. You don't need. For example, Dr. Rosenthal, intraoperative, delete air from chest and delete drainage. But you have very good results, but my opinion, need perform neuromonitoring. Is it good that you don't have complications? For our experience, when we remove this hernia, very nice, and put hemostatic, and after neuromonitoring show us that we have not impulse. You remove hemostatic and the normal after that. Thank you very much. Thank you for the comment. And may I say that these are the cases that is not usual as we see in the practice and not usual for our clinic. We only tried to present the case and some possible solution in the day where minimal invasiveness is everything. That is also mini thoracotomy as we think. And we kept the drainage only for 3 days to follow the patient, and there was not significant wound pain and not intercostal neuralgia after that. You have very nice results at my celebration. It's your start. My comments not for that for you, but perform. That for future, yeah, you to think can about. Okay. Transform your operating techniques. Thank you very much.
Thank you.
Thank you very much for the nice presentation. Well, the thing is, it is according to the surgeon's, best feeling to do that kind of surgery. And I don't mean that you're doing something wrong. You do a great job. In my place, what I'm training my fellows and residents for the desk osteophyte surgeries, even in the thoracic region, 1, 2, 3 levels, we sway away from the anterior approach by doing just the transpedicular decompression. We do generous laminectomy to give some plasticity or space for the cord to move, and then we use the pedicle itself, do a tunnel inside of it, just keeping the cortex, hiding and taking a tunnel on the posterior part of the vertebral body to make space. And with the down-going current, we break everything, even the desk osteophyte, into that gutter we are having. Just putting a couple of screws above and below, one above and below, and that's it. We get very good results with that, but again, we feel that doing thoracotomy for such surgeries is something big. I don't know about you. Thank you.
Thank you for the comment. May I say that this is one level thoracic disc herniation. It was calcified. That was the reason we think about the anterior approach. And as I said, the fusion is for us like another surgery. So we tried to do, as we harvested the rib head, we tried to be minimal or less invasive at the end of the operation, and that's why we use the rib head in the same surgery. So I think that the result is not bad, as you said. I'm not defending it. I'm just representing the way or the point of our view. Thank you.
I could comment also. The time is, is there any another question? It's time for the discussion, so if you want to sit, we can continue or just connect with this case on lecture. For the single level thoracic disc herniation, even with the osteophytes, of course, that the option if it's posteromedially or positioned the osteophyte, we should thinking about the anterior approach. But for any other cases, first of all, if we have to see where the micrated disc or osteophyte is positioned, is it lateralized to left or to right, and then we will choose this approach. Of course, whenever we can choose the right side, it's much better, especially below the T6, T7 because of Adamkiewicz artery, so go to the right side to escape to find Adamkiewicz. We don't know is it on the levels T7, 9, on 10. However, I would like to escape. And second thing, I usually, for this kind of surgery, I agree with Dr. Attia. For me, is much comfortable, and I'm familiar with the simple posterolateral approach. Just drill the part of the pedicle, 1/3 medial part of the pedicle and part of the transverse, I mean laminas. You have enough space, you have good view, just touch the, you know, we are fear of the medulla to injure at something, but you know, it's covered by the dura. It's also, inside is the ventral and posterior CSF pathways. They keep the spinal cord intact, so we can touch it a little bit, don't worry. So just go laterally and touch it, move it a little bit to the posterior or contralateral side if you have good enough view, and then you can drill with diamond drill, not use Kettering drill, but diamond drill through this lateral, posterolateral approach. You can solve this problem. But great job, you did great job, and I agree. Congrats. Any other comments or discussion for any lecture we had today? So we can conclude this session. Thank you very much to all of you, and enjoy tonight and dinner.